And don't read out my slide, just give a brief summary. You don't need a long introduction. I will also quickly cover up and then yours will be senior concern head of
Going live, huh?
Yeah, sure. And don't read out my slide, just you don't need a long introduction. I will also quickly cover up and then yours will be senior concern head.
Going live, huh?
Yeah, sure.
You are live now.
So do we start?
One second. Attendings are getting added. And there is an echo, Shamla, Dr. Shamla, you'll have to turn off the second device. You have a second device? Huh?
You are live now.
So do we start?
Attendings are getting added. I'm getting echo, Dr. Shamla. You have another device which is on?
No, I haven't.
Anyone else in the panelist has got another device on?
Is there an echo now? I just filtered the whole thing. So now
I think now it's okay.
There is an option for filtering. So I filtered now. Hopefully it should not happen.
Yeah. Okay. Perfect. All right. Okay. We can start. Over to you, Dr. Shamla.
Good evening. Good evening to one and all. Welcome on behalf of the Mamala Neocon team to the online lectures of the W18 workshop. Lots of effort has gone into curating the content of the talks today and tomorrow. You have eminent faculty talking to you here from India and abroad and updating you on the absolute latest in monitoring critically ill neonates. Of course, the timings are odd, 7 to 10 p.m. because this time was chosen because of faculty from abroad. Hope you learn as much as we have when we were putting together the content, and hope you're able to apply these concepts in your day-to-day practice in the NICU. We wanted this to be an icebreaker as far as topics go, so that you're able to make more of the physical workshop at Apollo Children's Hospital on this coming Thursday. There is a cyclone brewing in Chennai, and I hope all of you have your internet connections alive throughout the session. Without further ado, I think I'll hand you over to Dr. Kiran More, who's been the prime reason for this workshop. And I hope this will serve as a good introduction to our theme of critical care monitoring. Do post your questions in the chat box, and they'll be answered at the end of the talk. And I hope we are able to adhere to time and complete by 10 p.m. Dr. Kiran More is Senior Consultant Neonatologist and Head of the Department at MRR Hospital, Children's Hospital at Mumbai. You've seen that he has a lot of research interests, and he's had many fellowships and degrees to his credit. He has a lot of publications, and he's been the former president NNF Qatar branch, and he's also associate editor for NNF Journal India and the Wadia Journal for Women and Children. So he's been all around the world. So I'm sure we'll be much enriched by the topics he's chosen today. Over to you, Kiran.
Thank you, Dr. Shamla, and thank you for being a very nice co-host. And Dr. Shamla, she's a local coordinator and organizer, and she's put in immense effort to coordinate everyone, and that all the efforts will be reflected in the next week, the physical workshop. She doesn't need introduction definitely in Chennai, and she's been very active. She's heading the Department of Pediatrics and a neonatal consultant in Apollo Children's Hospital, one of the good units where we'll be hosting the workshop. And as you can see, she's very academic, lots of activities, and she's a reviewer and researchers, and good number of publications. And thank you very much, Dr. Shamla, helping to create this workshop. I'll just go over before we start. We'll quickly go over this thing, and we also have Dr. VC Manoj with us. He's NNF president for 2025. And again, he doesn't need introduction. Very academic person, very lots of research and publication, and he's been kind to give us the platform Learning of the Legends, which has really marked um, uh, online platform. You know what an online platform can do to post COVID, which Dr. Manoj has proven. And that's why, with a lot of requests which came to us about allowing these talks to be freely available, and Dr. Manoj kindly agreed to release it on Learning on the Legends, and that's why we have more than 100 attendees already, and we thought people will get benefited with this content which we have created. And I think Dr. Manoj has been instrumental in suggesting this workshop as an innovative workshop. So few words before I start, Dr. Manoj, just few words from you before I go with the program.
Thank you, Kiran. Hello, friends. Hearty welcome to both the Learn from the Legends platform as well as to in Mamalapuram NeoCon, the national conference of the annual national conference of National Neonatology Forum India. We have a lot of guests from abroad already who have joined, and then we are honored to have this platform is honored to have more than 11,000 registrations, and then I'm sure the knowledge transfer and the exchange of ideas would be preferential. And this intensive care today is going to be an overview of what we do every day in our neonatal intensive care units. And then it of course it cannot be complete in every aspect, but then certain things. So we would invite all of you to have the hands-on session also, which is there on the 5th of December at Chennai, India. That is, if you are interested and if you are able to attend, again, that is the time to meet and be part of the team. We would anyway try to develop this concept into something bigger in the next year. And we have an excellent team of faculty led by Dr. Kiran More, and then, of course, Dr. Shamala. So over to you, Kiran. All the best for this workshop.
Thank you, Dr. Manoj.
So thanks a lot, Manoj, for widening our reach. So I think you've made a huge difference to the way the workshop's being launched.
Thank you. Thank you.
Right. Thank you. We also have other faculties, but we'll introduce the faculty as we go. I'll just quickly start with introducing the plan of the workshop. One sec. So again, so for those who have registered and shown the interest, thank you very much. And I'm sure there is a lot coming for all of you who will be participating and who will be, actually coming physically for the workshop. I'm sure there's a lot to learn when you actually come for the workshop. Basically, I would like to share just a couple of minutes extra, because this idea came from NNF Scientific Committee, uh, Dr. Sushma Nangia, Dr. Surendra Bishra, and Dr. VC Manoj. And I just got a mail saying that, okay, we want to create some innovative workshop of critical care monitoring. Now, only the title was given, and we thought, okay, what can be covered in the critical care monitoring? And when we started brainstorming, I spoke to Dr. Shamla and some of my other colleagues, and we came up that okay, there is a lot can be covered in the monitoring, and in fact, all the intensive care is related to the monitoring. So it covers all the aspects, not only the respiratory, but cardiovascular, but also hemodynamics, neurocritical, everything. So it covers all the aspects of the work of the neonatal care. So basically, what we have done is like because the content was so much to cover, we got this lectures to cover in this weekend, and then the all the practical aspects is covered with a revision starting in the workshop. Revision of all the whatever we covered will be covered on the day of workshop, and then the workstations we cover the hands-on of each and every device we will be covering. Now these 2 days we have divided into kind of a respiratory or basics on day one, and then little bit advanced on day two. So we will start off with very basic talk with Dr. Bave, which I'll introduce shortly. But on foundations of clinical monitoring, whatever day to day we are looking at, blood pressures, cap refills, etc. Then we'll go on to little bit complex multimodal assessment of the systemic blood flow, adding little bit of the echo, but understanding the physiological concept of it. Then we'll move on to the monitoring of the saturations and how we can utilize the saturation monitoring with the help of trends and what saturation targets we should work out, automated FIO2 control. Then we'll talk about transport. Um, Also that monitoring during the transport, Dr. Anish Pillai will talk on. Then we had a talk from one of other international faculty, but she couldn't make it. So that's on more on oximetry and sleep study, and I'll see if we get time. We'll try to cover that topic also today. And then tomorrow we'll going again into more complex topics. We'll be talking more on two of the sort of, one is AI based analytics, using Hero, Comet, and other, how vitals can be analyzed in a different way, followed by needs monitoring for neurocritical care, then non-invasive cardiac output monitor, and then looking at the neurocritical care, Dr. Khurshid will be covering that. And last but not the least, we'll be talking about telemonitoring in the NICUs, how the different distance NICUs can be connected to a central monitoring, and how we can utilize this information. So to cut the introduction and go on to the topics, we will start with the first talk, and I'll quickly introduce Dr. Bhavya Shah. She's a consultant neonatologist at MRI Children's Hospital in Mumbai. She has 7 to 8 years experience in neonatology, and she's worked in all good centers in Mumbai. And she's also echo and POCUS trained, and also ECMO trained. And she's a good person to start with the basics of monitoring, which we do routinely in day to day in an ICU. So over to you, Bhavya. I'll stop sharing. You can start sharing your screen.
Thank you. Thank you, Dr. More. Thank you for such a kind introduction. I will just share my.
Yeah, and you can go full screen.
Yeah, we're good. Am I
Perfect. You're good. Good. Yeah. Thank you.
Okay. So at the outset, I would like to thank the organizers, Dr. More, Dr. VC Manoj, for having this brainwave of having this critical care monitoring workshop, and Dr. More to actually put everything together and get me involved in this. Without further delay, we'll move on to the rest of the talk. So without learning about the basics, or without just brushing upon the basics, it's going to be tricky to move on to the advanced talks of the days. That is what I'll be taking. I'll be just taking a comprehensive look at the basics for you. The scope of this lecture is basically we'll describe each and every parameter, which is a basic to just get to our hemodynamic monitoring. We will talk about the different signs of hypoperfusion and how to define shock, the current NNF CPG consensus statement. So our basic hemodynamic monitoring basically includes clinical signs like the cap refill time, the blood pressure, the core to body temperature, the peripheral and central pulses, urine output, and altered mental status. And it also includes biochemical parameters like your blood gas parameters, your pH, base excess, lactates, anion gaps. But the clinical signs of compromised perfusion are usually late. They show up in uncompensated or decompensated stages of shock, the sensitivity of which is only 55 to 70%. They're usually present when the baby has already reached the irreversible stages of shock. So this was an international consensus survey done for the diagnosis and management of, basically it was just a survey for how we went about diagnosing and managing hypoperfusion and hypotension in an extreme preterm, which was conducted in 2014. And you can clearly see over here that 95% of the times cap refill was the only way we decided that this child is now going into shock, or this LGAN is going into shock. Though we know by now that all of these other parameters, whether you count urine output, whether you count heart rate variabilities, whether you say color of the peripheries, color of the base deficits, the lactates absolute value versus the trend of lactates from the initial one till the progressive lactates, the pH, the overall neurological status of the child, the core to periphery difference of the child, and the hemoglobin, all of which also play a significant role in hypoperfusion. To elaborate upon this, so basically, no discussion about hemodynamic conditions or shock is complete without having this part of the talk. So shock, or basically our hemodynamic conditions, are a composite of these three parameters, which is preload, which includes basic intravascular volume, contractility or the pump, which implies your myocardial contraction, heart rate, and afterload, which is basically a vasoreactivity. So elaborating upon this a little further, so basically like what we said, your afterload, your preload, and the contractility, they imply or they affect the cardiac output, but the cardiac output is with the systemic vascular resistance, basically gives you a blood pressure. So you might have a normal blood pressure, but that is because of an interplay between the systemic vascular resistance and cardiac output, but the child might still be in signs of shock. Heart rate also plays an important role because heart rate and stroke volume help in giving us a cardiac output. Now, this cardiac output then determines your target organ flow, which decides about the oxygen delivery and the cellular tissue metabolism. Not to forget a very important component of cellular metabolism, which is hemoglobin and the oxygen carrying capacity of the hemoglobin. So both your hemoglobin with the percentage saturation of hemoglobin with oxygen will determine the blood oxygen content, which also decides the oxygen delivery, which then decides about cellular metabolism. So this is all sounding very basic, like what we've been taught in physiology and pathophysiology classes, but each and every component plays a very, very significant role in tissue organ perfusion, which is what the aim when you're treating shock is. You want to have an intact end organ perfusion, and that's why each and every parameter plays a very, very significant role, and this slide is of utmost importance. So we'll move on to each and every subheading now. As you know, heart rate in a neonate, the normal value is 160. Usually in a resting state, they are low, but they're higher with activity, crying. And usually a normal heart rate would have a normal sinus rhythm. Occasionally, when a child starts to develop tachycardia, and if that is sustained, you should assess for signs of shock. Okay, you might simultaneously want to look for signs of respiratory distress. You might look at BP, you might look at pulses, all of which we're going to come to in the next few slides. But as we said, heart rate also determines cardiac output and oxygen delivery, as we said in the previous slide. So sometimes when the child is extremely tachycardic, that might be the initial sign you might be noting in the ICU. And that should always keep your antenna up, whether this is a sinus tachycardia or whether it is associated with other scary signs associated with delayed CRT or core temperature difference, so on and so forth. Next sign that we're going to discuss is blood pressure. So the blood pressure has, there are various methods of measuring a blood pressure. Ideal would be an invasive or an arterial blood pressure monitoring through the umbilical artery or a peripheral artery like a radial or a posterior tibial vessel, posterior tibial artery. But invasive arterial monitoring is not devoid of its fallacies. Ideally, you would want your umbilical artery to be in a good position to not have a risk to your renal perfusion or your gut perfusion. Second issue is the damping effect that it can have if it's not receiving a continuous infusion. So in case you do not have a waveform which is correct, or if it doesn't bleed out, then you might, if it doesn't have a backflow, you might have to consider probably blocking and get the arterial line off. The other common method of measuring blood pressure is usually the oscillometric measure using a cuff. Your appropriate size of the cuff should ideally be at least the diameter of the cuff should at least be half of the circumference of the arm or the leg, the limb to which you're connecting. So these are usually the cuffs that we use in the NICU, where the extreme preemie usually gets size 1, and then we move on based on the circumference of the limb you're going to attach the cuff to. Very important to decide the appropriate sized cuff, because that would help decide, that would help interpreting your blood pressure readings accurately. So if it's an undersized cuff, it usually overestimates your non-invasive blood pressure. And if you have an oversized cuff, it is usually responsible for underestimation. Ideally, you would want to measure these non-invasive blood pressures in a quiet state. And in case you have abnormal findings, do not chase a single reading. You might have to take repeat readings, and you might have to correlate with other signs, as we discussed before and as we're going to come and discuss ahead. So the presence of hypotension is usually a late sign of cardiac decompensation. Blood pressure usually starts falling only in decompensated or irreversible stages of shock. So treat the shock based on your history, based on your clinical assessment, which is very important, based on your laboratory findings of end organ perfusion, along with the vitals, and do not chase single numbers. Check for the trend. When you're checking for a forelimb BP, which is ideally what you'd want to do in the when you're initially assessing your child, a normal forelimb BP, leg will be slightly higher than the arm. And in case of abnormal readings, usually your arm will be around 12 to 15 mm of Hg higher than the leg, in which case it might imply certain left heart obstructive lesions like interrupted aortic arch or coarctation of aorta. So ideally, you would want to maintain your blood pressure in the stage where you have an autoregulation phase for your cerebral blood flow. Okay, like we discussed in adults, where 60 to 200 is autoregulation pressures, and below 60 or above 200 is risky. Similarly, even in neonates, you have cerebral blood flow, which should be maintained within the autoregulation stages, because below which there will be cerebral ischemia, there will be a fall in cerebral blood flow, and above which there is a higher chance of developing IVH. So which centile charts to use? So there have been multiple discussions over the centile charts in the past. Some of these charts that we're currently using are as old as 1980 and 1990 based, but they're still currently extensively used because they have given us baseline characteristics, baseline cutoffs, all the way from 22 weeks of gestation till 40 to 44 weeks of gestation. So the one which is most popularly used is the Zubrov's charts, okay, which the Zubrov's charts basically are charts which have been developed from Toronto in the 1980s and 90s. So basically they give us cutoffs for systolic BPs and diastolic BPs, but not mean BPs from 22 weeks, also gestational age based or postnatal stage based, right from 22 weeks to 42 weeks of age. Okay, moving on, there is also a group of from the UK, that is a neonatal nursing network, which has put together charts for systolic blood pressure cutoffs, right from 4 to 24 hours of life till 2 weeks of age, and these have centile charts from 3rd to the 97th centile. There are other charts which have been taken in non-critically ill preterms and full-term infants. These charts basically have, these graphs imply less than 28 weekers, 28 to 32 weekers, 32 to 36 weeks, and then term gestation. And that's how they've compared the systolic. They've charted the normal values for systolic, diastolic, and mean BPs from 0 to 7 days of life, as well as at 30 days of life. So there are multiple charts that are available, and there are normative blood pressure data for even Indian neonates. So this study was done on stable Indian neonates, and they found normal values for systolic, diastolic, and mean blood pressure readings. I know the chart is a little crowded, but you will get it easily off the net. So basically it compares data. It gives us normal values for systolic, diastolic, and mean BPs, the 10th, the 50th, and the 95th centile, for right all the way from 32 weeks to 40 weeks of age. Finally, we've got a study which is correlating most of these charts, the blood pressure centile chart. So this study is basically available online. It's a neonatal blood pressure by birth weight, gestational age, and postnatal age. And it's a systematic review comparing almost 30 studies which are included in this, one of which is actually an unpublished study, where they compare their centile charts based on gestational age. And as said, as the gestational age increases, as the postnatal days increase, the blood pressure centile targets slowly increase. But despite the blood pressure increasing with birth weight, gestational age, postnatal age, there was a marked pressure variability observed through all of these studies, because most of these studies, there are no comparative studies done among these. Some of them are measuring blood pressure intraarterially, some of them are as an oscillometric study, and some of them with diapers, Doppler, some of them with photoplethysmographic cuffs, and some of them with sphygmomanometers. Future studies are still needed. So NNF-CPG has come up with guidelines to basically define mean arterial blood pressure ranges and define hypotension for preterm babies less than 32 weeks and less than 72 hours postnatal age. So these are the charts. At 22 weeks, the median MAPS, that is the mean arterial blood pressures, to be taken are 21. And then as we move towards 28, 29, 30 weeks, 27 to 29 are the median MAPS. And then beyond that, I think beyond 32 weeks, NNF CPG guidelines advise us to follow the Zubrov's charts. So when you want to compare your blood pressure to the cardiac output, and you want to consider whether this child is in a compensated or an uncompensated stop. So ideally, we would want to be in this stage where you have your ideal blood pressure, you have your ideal cardiac output, and your SVR is maintained. Okay, but sometimes your blood pressure, though maintained, the cardiac outputs might be falling. And the reason why your blood pressure is maintained is because the SVRs have started to rise now. As we saw in the previous slide, basically, blood pressure is a component of cardiac output and systemic vascular resistance. So if your cardiac output is falling, initially the SVR might continue to rise to maintain your blood pressure, resulting in a state which is called as compensated shock, in which some of your parameters might continue to remain normal. But if shock is not caught in this early state, we might move to something which is an uncompensated shock, where both your blood pressures and cardiac outputs are falling. So the whole reason for conducting this and all the further lectures is basically to find ways of catching shock or catching stages of hyperperfusion early, so that we don't move on to uncompensated shock where we do not have intact end organ perfusion. Moving on, just by assessing the color of the child. Okay, normally, except for the first probably 24 to 48 hours when you might note acrocyanosis in a newborn child, usually the child should be pink in color. Acrocyanosis is basically implied by peripheral cyanosis, the bluish discoloration of hands and feet. Usually mucous membranes are not involved, often resolves by 24 to 48 hours. If you get it beyond, if you notice it in a child beyond 24, 48 hours, do rule out cold stress or moderate to severe hypothermia. Circumoral cyanosis is a bluish discoloration around the mouth, may be associated with feeds, and do rule out central causes. Central cyanosis, this is the discoloration of the tongue and the mucous membranes. It's caused by desaturation of the arterial blood. It indicates cardiac or respiratory dysfunction. Basically, it's hemoglobin is not carrying enough oxygen, as a result of which you have reduced hemoglobin circulating. Cyanosis may be visible if 3 to 5 grams per deciliter of reduced hemoglobin is in circulation. Skin perfusion can also be assessed using cap refill time. Normal cap refill time should be less than or equal to 3 seconds. How do we measure cap refill? So basically, apply pressure on the sternum, okay, and you can apply this pressure and count to 5. And then beyond that, you release that, you should see blanching of the skin. And then while you're releasing it, you also end up counting 1, 1000, 2, 1000, 3, 1000. So if you have your blanched skin refilling with color within 3 seconds, you have a normal cap refill time. When you're checking for cap refill, also consider comparing your cap refill between upper body to lower body. So the lower body might be at the level of at knee when you raise it to the level of the heart, to compare basically that there is no CRT differences between your upper and the lower extremities, because that would also imply, if you have a difference between the upper and the lower extremities, it might imply some left heart obstructive lesions that, along with a temperature difference between upper to lower extremities, might also imply something which is more ominous. So CRTs may be abnormal. CRT can be slower in the lower compared to the upper body, like we just discussed. If there is mottling present, compare that sign, keep that in mind while you're considering all the other signs that we're discussing. Keep a watch if there's pallor, keep a watch if there are cool peripheries. Consider also keep a watch if there's diaphoresis, that is sweating on the forehead and the scalp, which might imply increased sympathetic activity and with reduced cardiac output. So yes, a CRT is also an important indicator. And in fact, initially CRT was, like we said, almost 95% in the survey. It was found that almost 95% of the people diagnosed shock with CRT. Though now we know that it's not the only marker and there are lots of other markers which are of much more importance. So clinical signs of poor perfusion would then, like we'll reiterate, skin mottling, cap refill, peripheral and central pulses, cyanosis. Pulses, these, so normally your pulses should be easy to feel. As long as you know where to feel them, they should be easy to feel. So brachial and femoral pulses should be equal in strength. Pedal pulses should be palpable, and pulses should also be equal right to left. This is abnormal if the pulses are difficult to palpate, in which case you might have to consider shock, early stages of shock, if these are peripheral pulses, or signs of cold stress. Also compare your brachial with femoral, or even if you compare and your right brachial and the left brachial are not equal to feel, can consider coarctation. And if you have bounding pulses, consider PDA, large AVM, or a trumpus. Moving on to the next sign, that is the perfusion index. So this is something which is easily available through a pulse oximeter on our monitors. It's a small reading which is usually ignored, but it is extremely important, and we will tell you how. So a perfusion index reflects the amplitude of the blood flowing through the peripheral tissues, especially the capillaries. This is usually provided by the pulse oximeter. So if you have a good pulse oximeter reading without an artifact, without a motion artifact, and you have a good plethysmograph, then you should get a perfusion index, which is relatively reliable. So this gives us a real-time change in the flow of peripheral blood. It's relatively unambiguous, offers more clarity, and is an independent marker. And occasionally, there are studies which have also shown that pulse variability index, which is the minimum and the maximum PI over a defined period of time, also has an 86% sensitivity for volume responsive hypotension. The only problem is fallacies. Some studies have said, obviously, since it is read by pulse oximeter, to have a stable plethysmograph is important for finding a perfusion index reliable. Second is to have reliable perfusion index, readings should be taken in the same altitude. Ideally, it is preferable at sea level. So there are multiple studies which have spoken about perfusion index, peripheral perfusion index. So this is a Chinese study which is done on newborns, almost 1,000 in number, for healthy newborns. And they've given the cutoffs for gestational age and sex in China. Both pre and postnatal cutoffs are also given. And usual ranges are 1.5 to 2.4. But perfusion index slowly improves over the first couple of hours of life till it's stabilized by 24 to 48 hours. And then usually it should remain stable. It should remain within a certain range. We ourselves also had a study which was conducted in my previous institute at Wadia Children's Hospital, which was on utility of serum lactate and perfusion index in predicting morbidity and early mortality in very preterm neonates. So we recruited around 130 neonates, and the PIs at 3 hours and 12 hours versus the lactates at 3 hours and 12 hours were compared to morbidities related with prematurity like IVH, BPD, long hospital stay, NEC, and mortality, first week mortality in the NICU. And we found that PI was not reliable, but serum lactate at 12 hours of life with a cutoff of 5.5 millimoles per liter was significantly associated with mortality in the first week of life. Last couple of slides. So neurological status is important because once the perfusion starts getting affected, if you move out of your zone of autoregulation, the cerebral perfusion will also start getting affected. Cerebral blood flows will get affected. As a result of which, signs of early signs of deterioration like poor feeding, weak suck, disinterest in feeding, with eventually worsening to distressed hypoxic cries, irritability, lethargy, poor activity, flaccidity, comatose condition are all going to imply that the cerebral blood flow is affected, which is not something that we'd want. We'd want an intact end organ perfusion, especially in the brain. Temperature. Thermoregulation, as we know, is extremely essential in newborn babies, and we have lots of ways to maintain temperature. Sick infants are more likely to be vulnerable to heat losses. So thermal support should be provided at all times, including in the ER, labor delivery room, nursery, and transport. Use a radiant heat source. Occasionally, during transport, might have to use a chemical thermal mattress, warm blankets. In extreme preterm, we do use our food-grade plastic or cling wraps, and we might have to use caps. So the core periphery temperature gradient, core temperature monitoring sites are usually rectal, axilla, abdominal, interscapular. Rectal is not practical for continuous monitoring because it might get accidentally pulled out. It's difficult to maintain at the same depth. And occasionally it is not reliable during peripheral vasoconstriction. Axilla abdominal is relatively reliable. Axilla is a good site as it doesn't interfere with our X-ray fields if we want to shoot an X-ray. So core periphery temperature gradient, normally preterms have a difference of 0.5, which lengthens out to 1 degree Celsius by day 3. And term babies usually have a core periphery temperature difference of around 1 to 1.3 by days 3 to 5. So as you can make out in these charts, the peripheral temperature is the first to fall, followed by the core temperature in case of cold stress. In case of heat stress, both core and periphery work relatively simultaneously, but in cases of early signs of infection, we have our core to periphery temperature difference, which increases. So if it is more than 3 degrees, it usually implies that there is some signs of late onset sepsis kicking in, and we might have to do more than what is going on. So there is a consensus statement on what are the parameters to basically define organ perfusion. And apart from the cardiovascular parameters of fluid refractory shock or the parameters for inotropes, our core to periphery temperature difference of more than 3 degrees Celsius, prolonged CRT of more than 5 seconds, oliguria with a urine output less than 0.5 mils per kilo per hour, increased arterial lactates of more than 2 times upper limit when we take around 1.5 milliequivalents per liter as a normal cutoff, unexplained metabolic acidosis with a base deficit of more than 5 milliequivalents. 2 of these parameters, in addition to the need for fluid resuscitation within the first hour of life, or the need for inotropes like epinephrine, norepinephrine, or the need for inotropes like dopa-dobutamine at doses more than 5 micrograms per kg per minute, are signs of organ dysfunction for diagnosis of septic shock. So just to summarize, I know cap refill is initially used by us for predicting cardiac output states, but it has its own limitations. So moving on, we have blood pressure, ideally invasive, but we also do non-invasive when invasive is not possible or associated with risks in our units. But do not believe that a normal BP means a normal cardiac output or a normal hemodynamic status of the child, because occasionally in stages of compensated shock, we might have a normal BP, but we might still have low cardiac outputs because the SVR is initially compensating. And then eventually, when you start falling, when the SVR starts falling, the child might become vasoplegic, is when your BPs will start falling. But this is the point of no return when end organ perfusion is already affected. And this is the stage of irreversible or decompensated shock. So blood pressure does not tell the whole story. All the numbers are equally important, and how we're going to monitor these numbers is what we're going to work towards in the next few lectures. Urine output, lactates, pH, obviously these are important, but these are late signs after decompensation has already occurred. So the sensitivity, like we repeating, 55 to 70%. So the goal or the motto of managing critical care monitoring in the NICU is early prediction, early intervention, and ongoing monitoring to assess for any improvements or worsening. just completing this talk with having a brief discussion on NNF-CPG guidelines. This is the same as what we've discussed previously. So the criteria may be used for impaired tissue perfusion are in less than 32 weeks and less than 72-hour child. We use the GNN guidelines for BP monitoring. In less than 32 weeks, but beyond 3 days of life, mean blood pressure is comparable to the gestational age. 32 weeks to 36 weeks, any age, it's comparable to the gestational age. Or we can use the Zubrov's normograms for diastolic BPs less than the 5th centile. This in addition to at least one of the following, that is CRT more than 3 seconds, urine outputs less than 1 mils per kilo per hour, lactates more than 3 millimoles, base deficits more than 8, and in a term neonate, core to periphery temperature difference of more than 3 degrees Celsius is implicative of shock. This slide is basically going to tell us that there are multiple ways of assessing preloads, cardiac function, afterloads, and end organ perfusion. What we have discussed is a small component of what all needs to be covered, what all we will be covering in the next few talks tonight, tomorrow, and what we will be doing in person physically in the workshop that we're conducting. So stay tuned for more. Thank you.
Great. Perfect. Great start, Bhavya. We're a little behind time, but very well covered. I think these are covered topic for basic, because that's kind of a bread and butter for monitoring, which all of us are daily dealing with it. So bottom line is, yes, these are important, but we have to be mindful about fallacies, and more parameters we monitor, sort of more information we get, and we are more closer to the real assessment of the hemodynamic status of the baby. So I mean, there were a few questions about few
Yeah,
comments. That's a
looking at
good
that.
talk. Perfusion index, again, I hope there is no confusion about pulsatility index and perfusion index. Pulsatility index is different. We are talking about perfusion index. So just one line again on recap about accuracy of perfusion index, any cutoffs, and how important it is. Just one sentence if you can cover, Bhavya.
So perfusion index is slowly increases from the first day till 48 hours of life. 0.7 to 0.9 are the cutoffs usually that we take in the first 24 hours. And beyond the 24 hours, 0.9 to 1.5 are the cutoffs we take. So if you have a perfusion index below 0.6 on day 1 or below 1 on day 2, usually it is in a stable plethysmograph, usually is implicative of something which is a poor perfusion, early sign of shock.
Great. Yeah. So, I mean, just train your nurses so that they do look at the PI values and look at the plate, because otherwise, a crap perfusion and a crap recording, they will document a falsely high number of desaturation events, and your decision will change. So, again, it's an important fallacy of the monitoring. They need to be, the machine should be accurate, the perfusion of the baby should be adequate to get the saturation value which is accurate. Otherwise, you will unnecessarily give over oxygen, or you'll not wean the support earlier if the PI is not correct. So that's the important. Great,
Yeah, and to
Bhavya. Thank.
reiterate, all of
Yeah,
it has to be seen as something which is together, as a collaborative symptom instead of treating each and every number or sign separately. So yeah, yes.
correct. And I
Thank
think
you.
you covered enough on the blood pressures.
Yes.
So I think there are no questions on that. We can come back to you again on the questions.
Sure.
But thanks a lot. Thank you, Bhavya.
Thank
We'll move to the
thank
next
you.
talk.
Yes.
Over to, yeah, thank you. Over to you, Dr. Shamla. You can introduce the next speaker. Yeah.
Good evening, Kumaran. It's a pleasure to have you with us today. Do you want to display that slide,
Yeah,
Kiran?
it's coming. Yeah. Yeah.
So Kumaran is from Namma, Chennai. So we worked with Kumaran a long time back at Child's Trust Hospital. So he moved on to UK and Australia, New Zealand before settling down in Canada. He's currently director of the Zonal Edmonton Service for Targeted Neonatal Echocardiography and Hemodynamics. He's a neonatologist at the Stollery Children's Hospital, Northern Alberta Neonatal Program, Edmonton, and Clinical Associate Professor Pediatrics at Edmonton. So if I'm going to read all the material here, I would take the time of the next talk as well. So he's got a lot of interest in targeted neonatal echocardiography and hemodynamics. So over to you, Kumaran, to give us an overview of echocardiography in newborn. So
Thank you. Thank you, Shabla. And thanks, Kiran. And thanks for NNF organizing this and inviting me. Let me share my slides. As Shamla said, okay. I hope this works out right.
Perfect. Yes, we can see. And
Okay, let me just start.
perfect.
Okay, so you can see that? Yeah.
Yep.
Okay, great. So my talk is basically multimodal assessment of systemic blood flow in infants. I wasn't planning to do a primary echocardiography talk. So I wanted to look at how we can assess systemic flow in a multimodal manner. I think that's the intent of the talk. And you're going to see a lot of overlap with Dr. Shah's talk. And I think thanks, Dr. Shah, for making my life easy. You might also see a lot of repetition, but I think sometimes repetition is important and repetition is reinforcement. And hopefully I'm able to cover a different aspect of what was discussed. Because I think more and more when we have technology, we want to emphasize the importance of clinical factors, the value of it, and the fallacies of it, and the limitations of it, And I think that is what we want to emphasize. So today's objective, at least my objective, is to ask the question: what is systemic flow, and how do we monitor it? Clinical laboratory, sonography, spectroscopy, and putting it all together. And maybe we can do how we can put them all together and come to some kind of conclusion. I think that's the idea. Well, I thought I'll start with a quiz. Maybe if all of you have a phone or computer, please, go to menti.com. The quiz is about a baby M who's 26 weeks gestation, 6 hours old. I just have to figure out how to do this. 1 minute.
Just
Let's see.
I think many may not be aware. So they have to go to menti.com and enter that number,
Yeah.
right?
Code, yeah. And then code. I'll come back to that in a minute. And I just
Perfect,
wanted to
okay.
find out a way to share my screen instead of is there, yeah, I can just go back and share this. So if you go to menti.com and then put this number 9834207, and it's a 26-week gestation, 6 hours old, ventilated on 21% oxygen. Arterial blood pressure is 26/17, mean is 20. Urine output is 0.5 ml per kilo per hour, lactate is 0.5, and CFT is 2 seconds. So let's give about 30 seconds or so and then see, I hope you're all able to see my screen. There's more piling up. I think there may be more quizzes towards the end, so I want people to get used to this idea. Okay, that is good. What I'll do is I'll go back to I think I see 13 responses for none of the above, and some responses for dopamine, some responses for dopamine. What I think I will do it is to ask you to hold that thought, and then we can go on with my talk. Okay, so just hold that thought for now. So the question that we would be asking is, should you be treating the blood pressure or the systemic flow? So that is the question that we want to ask. Essentially, shouldn't you be treating the systemic flow? That's the question that we want to ask here, right? So I think we'll come back to the same question and talk about it later. And I think Dr. Shah went through in detail about what is systemic perfusion, what is the definition of shock. And this is one of the definition of shock, which shock can be summarized descriptively as a circulatory impairment leading to a state of impaired oxygen delivery to the tissues. With that definition, and as you can see, impaired oxygen delivery to the tissue is the message, right? So when you really think about it, if you look at this picture, it clearly exemplifies the importance of regional perfusion as well as the systemic perfusion. So, and I think what we are interested in, we want to prevent regional embarrassment of the tissues. And I think that is the whole focus. And systemic flow is the focus, which results in good systemic perfusion, which is what I think we want to maintain. So then that makes us ask the question, how do we monitor the systemic flow? So when we look at systemic perfusion or systemic flow, the way we would monitor is clinical assessment. Clinical assessment includes blood pressure, capillary refill time, heart rate, perfusion index, and urine output. I think we had enough discussion about all these things. Maybe I might just go through one slide each and see if there are any aspects that we can talk about it differently, but I'm going to spend a lot of time on blood pressure. The labs are the acid-base balance and hyperkalemia, echocardiography, cardiac output and SVC flow. We can talk briefly about it, and cerebral oxygenation, NEARS, and I think we can start briefly about it. And putting them all together is the whole idea that we're going to talk about. How are we going to assess systemic flow? So we know that blood pressure is a product of cardiac output and systemic vascular resistance. And if the systemic vascular resistance goes down, cardiac output is going to increase to compensate, right? And maintain the blood pressure. And that either you will have a low normal or a normal blood pressure in that situation. That'll be a vasodilatory physiology. And if the systemic vascular resistance goes up, cardiac output is going to go down, and then you're going to have a vasoconstrictive physiology. And I think that's what is going to happen. And I think we saw this again. I think we're going to come back to this. And I think any hypotension or a systemic flow talk, it is difficult not to put this graph. As you can see here, where we want to be is in the normal, where your blood pressure is normal and your cardiac output is also normal. But as we discussed with Dr. Shah's talk, most of the time we end up, babies compensate for low systemic flow, and they compensate for the shock. So the blood pressure, even though the cardiac output is low, the blood pressure is maintained by the compensatory mechanisms, and so you get compensated shock. So the trick is to catch these babies when they are in the compensated shock, and of course, we all know uncompensated shock, you're going to have a low cardiac output and a low blood pressure. And of course, there is a hyperdynamic circulation when you have high cardiac output, and there will be a low blood pressure. So low blood pressure can indicate doesn't indicate necessarily a low cardiac output scenario. And a high cardiac output doesn't necessarily, or normal cardiac output doesn't necessarily indicate you are in a safe systemic perfusion scenario. And I think that's an important piece that we have to understand, because hyperdynamic circulation can have different pathophysiologies. So this is, again, what is mean arterial pressure? It's influenced by cardiac output and systemic vascular resistance. And in turn, if you can see this complex diagram, systemic vascular resistance is influenced by your vascular anatomy, vascular factors, and tissue factors, and also the neurohumoral factors. And when you go into cardiac output is influenced by and large by stroke volume and the heart rate. And heart rate is influenced by neurohumoral factors. How these complex mechanisms interplay is what I think we want to show here. And stroke volume, in turn, depends on the preload, right? So what comes into the heart, I think that determines the stroke volume. And also the inotropy of the heart, whether the heart muscle functions well or not. And preload, we know it in turn depends on venous compliance, which is influenced by neurohumoral factors. And preload is also dependent on the blood volume, which again, the renal handling of sodium and water determines that. So if you really look at it, what we are seeing as a mean arterial pressure is just a tip of the iceberg, and a lot of things that goes on beneath that. And I think that's what I think we need to understand whenever we see a low blood pressure, or even a normal blood pressure, or even some sign of low systemic flow, at least a clinical sign. We want to ask the question, what's going on behind the scenes? What's under that iceberg, right? That's what I think we want to think about, so that we can actually address the management, exactly trying to address the pathophysiology. Let's talk about the blood pressure. So blood pressure, as we know from the first talk, is a poor predictor of systemic flow. So if you look at how do we know this? Now, we're going to talk about superior vena cava flow. This is one of the echocardiographic techniques. What it essentially determines is how much blood flow is coming to the heart through superior vena cava. And I think Martin Kluko and his group, they showed that that is the most, at least reliable indicator for systemic flow. And I think, so there is a controversy around that, but so far, if you really look into the literature, the only reliable indicator for systemic flow is the superior vena cava flow. And if you look at whether the blood pressure in this graph, it's very clear, as you can see, there is no correlation between blood pressure and the systemic venous flow. Same way, if you look at left ventricular output as measured by cardiac echocardiography, also does not show a good correlation with your mean blood pressure. And so BP parameters, they correlate poorly with left ventricular outflow as well as systemic flow. And of course, we spoke about, I think Dr. Shah nicely spoke about the measurement technique, whether you are doing non-invasive blood pressure measurement or invasive blood pressure measurement. I think there's a lot to do with blood pressure measurements and its reliability. But if you really look at overall, I think into the literature, the general consensus is it's possible that a simple BP threshold that indicates a need for therapy does not exist. And other factors like clinical status or systemic blood flow measurements may be more informative. And that's the paradigm shift. And I think this is recognized as early as 2007. I think we are still making the shift very slowly. That's what I have to say. Still blood pressure, if you look around, and I think plays a major part in how we address management. If you look at how we got the mean blood pressure equivalent to gestational age criteria, this was actually decided in 1992 by a group of primarily obstetricians. And this is the British Association of Perinatal Medicine. And what they essentially said was, at the present time, that working group agreed that a mean arterial pressure is equivalent to the gestational age in weeks is adequate as a minimum value. So this is not based on any large data. I think it is based on expert opinion, and I think that's what I think I want to say. And I think still a lot of us are using that mean airway pressure, mean arterial gestational age as the mean blood pressure. And if you look at since then, what is available in the literature, people have tried to define what is the normal blood pressure for different gestational age groups. As you can see here, there are multiple retrospective studies, multiple prospective studies with various number of infants with varied gestational age, with very different cutoff values. By and large, if you look into the literature, I think most people will talk about a number 30. So 30 millimeters of mercury is generally considered a reasonable kind of a mean blood pressure to aim for. Mainly because most babies postnatally, irrespective of their gestational age, beyond over time, their mean blood pressure gets to 30 and remains there. And I think it's mainly the association. So that's how that number came into play. But as discussed earlier, Zubrov in 1995 came up with the large series, and I think Zubrov is still being used now. As recent as 2024, El Sayed from Winnipeg, they looked at 547 babies from 23 to 28 weeks prospectively, and they have come up with a very elegant blood pressure centile charts. And I think they have this NeoPeds Academy. Please feel free to visit that, where you can actually plug in the gestational age and the day of life, and then you will get the centile charts right from the 5th to the 95th centile for different gestational age for different age. And it's an elegant one, and I think it's not very dissimilar from the Zubrov numbers if you really look at it. They tried to use primarily invasive blood pressure measurements, so improving the validity of the same. So we looked at blood pressure, the reliability of it. We looked at blood pressure numbers, how to define what is the appropriate blood pressure and the centiles. The question is, how do centers treat hypotension? This is the Canadian Neonatal Network data. If you look at it, the proportion treated, almost, if you look at so many centers, 90% of these babies get treated for low blood pressure. And you can see the different low mean arterial pressure numbers that are used for treatment. And I think when they say any treatment will include either you give normal saline or vasopressor, and the same way. And I think, a sizable 50 to 70% of these, 65% of these babies do get vasopressor treatment. And, and then a variable number, if you really look at it, so, and we know from literature that treating hypotension per se results in harm. So more than hypotension per se. So this is when the concept of what are we treating? Are we just treating the number, or should we be actually looking at it further? And what are the side effect profiles for these medications that we use to treat? So going into the literature further, about the limitations of a treatment, if you look at volume expansion, as you can see here, this nice forest plot says no treatment versus treatment. There is no difference in the outcome of death. And this is an interesting study called HIP study. But of course, unfortunately, the HIP study was originally planned to be a multi-center study, originated from the UK and Europe and North America. They wanted to look at dopamine versus placebo for treatment of hypotension. And they could not recruit enough number of babies. So the study actually, they aimed to recruit about 200 odd babies, but I think they could get only 30 babies or so. So if you 60 babies or so, as you can see, the numbers were very small, but still, for what it's worth, they published it. Essentially, placebo versus dopamine, they couldn't really show any difference. Of course, we can always argue, the numbers were small, and it was discontinued quite early. But still, I think looking at this randomized controlled trial, and an important evidence in the literature. But if you look into the literature, there are a lot of observational studies. For example, this one looked at short-term outcome of very low birth weight infants with arterial hypotension in the first 24 hours. And they have babies from gestational age 22 weeks to 31 weeks. And infants with lower blood pressure seem to have a higher incidence of death, as well as intraventricular bleeds. But I think what I really want to show is we have to be careful when we are looking at associations, when you're looking at observational studies, either prospective or retrospective. they may show only association and not causation. As you can see, sunny weather, maybe you eat ice cream because of the sunny weather, and so because of sunny weather you get sunburned, but eating ice cream doesn't necessarily get you sunburned. That's an important piece. Same way sleeping with my shoes on doesn't give me a headache. It's what I did that gives me a headache. So that's an important piece that we want to keep reminding ourselves when we are seeing observational studies and not quickly jump into implementing outcomes based on observational studies. We want to ask ourselves, what is the quality of the evidence? Is it an RCT? Is it a meta-analysis? And then those are the things we want to look at. So if blood pressure is full of fallacies, then the question that we want to ask is it useful at all? Of course, it's useful, right? So what we are saying is everything that we do is useful, but we want to understand their fallacies and their role so that we can actually use it in an appropriate manner and understand and use it in an appropriate manner. Of course, we need to know the blood pressure number, and I think that's an important piece. It's a product of cardiac output and superior systemic vascular resistance. Essentially, I think the way to look at it is if you have a lower systolic blood pressure, I mean, what does that indicate? A lower systolic blood pressure, the pathophysiology underneath it is a lower LV stroke output. Now, the lower LV stroke output could be because of a low preload, or it could be because of a contractility issue. So these are the ways we can understand, okay, what's happening behind the scene. So either it could be a pulmonary hypertension because less blood flow go to the lungs, so less blood flow come back to the heart, so you have low systolic pressure, or it could be a septic shock or a cardiogenic shock. Same way, diastolic blood pressure, lower systemic vascular resistance, the pathophysiology underneath that. So systemic hypovolemia can cause that, right? Or warm shock, vasodilatory shock can cause that, or a Steele phenomena from PDA can cause that. Of course, when we are looking at both systolic and diastolic under the third centile, that's what we generally use in our center, then the pathophysiology is both, systolic and diastolic dysfunction. It could be any number of what we discussed so far. So that is the way. Maybe we can see when we put them all together, how we can use them. So what I think, again, I'm emphasizing here is one parameter alone doesn't tell you the whole story about the systemic flow. And I'm going to quickly go through these, and I think we spent a lot of time talking about capillary refill time and everything, but I may just have one slide. So the question that I'm going to ask here is, does it correlate with hemodynamics, right? And that's what I think of a question is for this particular talk. And I think what it shows is this particular, it does not, and I think that's what I think it shows. And the same way, does it correlate with cardiac output? And I think that's the question that we are asking here. The correlation isn't really that great, so it's no correlation with fraction shortening, no correlation with heart rate, no correlation with blood flow. Does it correlate with superior vena cava flow? Again, I think the same. If you really look at under 3 seconds, if you see the superior vena cava flow is, as you can see in this graph, you have SVC flow of 100, 150 mils per kilo per minute. That's quite normal or high. So it does not really correlate very well. Heart rate, we know heart rate is a wide range of normal values. Heart rate is influenced by a number of factors. So no relationship between heart rate and systemic blood flow shown in several studies. But heart rate variability is an interesting area that we want to look at. Maybe, and I know that there is a talk on the HERO monitoring, especially in the context of sepsis detection and beyond. And I think this is increasingly, we don't use it in our center, but I think we all would like to learn more about this. And I think there's more studies coming out about heart rate variability and its analysis in full-term infants, especially in cardiorespiratory control and things like that. So there's an area it'll be interesting to wait and see. I'm not going to spend any time on perfusion index, and I think we spoke about it in detail. So it is essentially utilizing the pulsatile blood flow and the non-pulsatile blood flow. So the relationship between them, that's what I think is used as perfusion index. A number less than 1.4 is indicative of reduced peripheral perfusion. Of course, this is in adult data, but of course, as we discussed a lot about its utility and its reliability. Now, this one slide about urine output is easily measured and often used as an indicator for adequacy of cardiovascular function. The assumption has several limitations, though. A decreased urine output, can happen before diuresis, and in preterm infants, there is immature tubules, so you may have normal urine output despite cardiovascular compromise, and that's an important piece. And in the first 24 hours, urine output is quite unreliable because babies don't void that much in the first 24 hours, and that doesn't mean that the babies don't have adequate cardiac output. That's an important piece that we want to remember as well. And hyperkalemia has been elegantly shown, to have a good relationship with systemic flow, and that's what this particular study shows. Acid-base status, again, I'm not going to spend a lot of time, but I think, high lactate levels and low perfusion index could be used as early parameters for prediction for retinopathy of prematurity and BPD. One of the things about lactate, as we all know, is when your tissue is denied of perfusion, it generates lactate. Sometimes lactate may not be high, even in the presence of severe hypoxia or tissue hypoxia, because there is no adequate perfusion to clear the lactate. So a normal lactate, does not necessarily mean there is adequate tissue perfusion, something to remember. Going on to the other aspects, using systemic superior vena cava flow. Now, this is primarily obtained by echocardiography. And what it does is, I think this is Martin Klukow and Nick Evans from Australia, and I think they were the ones, they showed the utility of SVC flow because the IVC flow is unreliable. But SVC flow seemed to had a good relationship with cardiac, with the descending aortic flow or cardiac output. So they propagated that as the most reliable factor for assessment of systemic flow. And there are reviews that looked at systemic flow measurement in the neonatal bifunctional echocardiography. And the general idea is they remain the best available methodology for for monitoring central perfusion. But do we know the normal values? Unfortunately, we don't know the normal values. As you can see in this, the normal values are all over the place, and they are low initially, and then they start to go up after the first 24 hours. And as increasingly questions that are being asked, that is it actually reliable? So our group recently did a systematic review and to look at, is it actually useful for neonatal outcome? And the group didn't find any evidence that SVC flow in early neonatal period as an independent predictor for adverse outcomes. So one of the things that I want to maintain here is anything that we are saying or talking, individual numbers may not make any sense and we can't really use them for decision making, but trending them is always useful. So if we started off with a high SVC flow and suddenly it is trending low, that's useful. If we started off with a higher blood pressure and it's suddenly trending low, that's useful. And I think that's how we want to start using, instead of just looking at one number at one point of time. Are we trending them over a period of time? Are we doing repeated scans, and does it actually make sense? Then we can go back and look at what's happening underneath. So again, I think there are studies to show that poor correlation with hemodynamically significant PDA. So the next question to ask is cardiac output as measured using echocardiography. As you can see here, the general assumption is left ventricular output is equals to systemic blood flow, right? Now, of course, from the body, blood comes back as venous return to the right atrium, goes through the right ventricle, And this is the whole thing if you really look at it. So I'm just gonna. So essentially, what here we are saying is the left ventricular output in a neonate, in a preterm neonate, in the presence of PDA, because blood goes to the lung and comes back to the left side of the heart, it will be an overestimate of systemic blood flow. Whereas if you look at the right ventricular output is what comes back from the system to the right atrium. And of course, it also includes, in the presence of atrial shunt, right ventricular output is also not very clearly indicative of systemic blood flow. And that's something that we have to remember when we are looking at left ventricular output as well as right ventricular output. Is there shunt present, and how much this shunt is influencing it? So that's an important piece. And that's why people went to, oh, you know what is the right number? Maybe SVC flow is the right number. So that's how they went for it. Now, how is cardiac output measured? As you can see here, and I think it's mainly for an echo, people with an echocardiography background. So what it's going to look at is looking at the valvular level, right, when pulmonary valve or aortic valvular level. What is the column of blood that is moving through that level? And then they usually assume it's a cylindrical column. And then they calculate the volume that is going across that valve. So that's how cardiac output is measured. And it's important to recognize the measurements need to be done in an appropriate manner. There has to be a particular angle, and there is going to be inter-observer variability and intra-observer variability if you don't follow the rules. So these numbers are given to a lot of mistakes. Again, trending them are useful than an absolute number. And I think that's the point that I wanted to say. Generally, as a rule of thumb, we say normal ventricular output is somewhere between 150 to 300 mils per kilo per minute. Now, there is some evidence, maybe not much of an evidence, I have to say, but I think there is one paper, but of course, which talks about if you have a low left ventricular output early on in late onset sepsis, they have increased mortality. But again, these are associations, they're not, based on RCTs, and that's something that we have to remember. The cardiac output can also be measured through in a non-invasive manner through bioreactants. And I think this is an area that we have to wait and see. Eugene Dempsey's group actually looked at it and compared it with echocardiography measurements of cardiac output. And they found that the estimate is slightly lower, but it gives you a nice trend, like on an ongoing basis, which just leads put on the baby. So this is an area that we have to wait and watch. And we don't have any personal experience in this. And I think, I'm looking into the literature to understand more. The other thing that we wanted to talk about quickly is about near-infrared spectroscopy. And I know that there's a talk here, but I'm just going to be very brief in the context of multimodal monitoring. As you know, what near-infrared, it is cerebral oxygenation is what we are detecting here by putting leads on the skull. The oxygenated hemoglobin and deoxyhemoglobin, their absorption pattern of light is different. So the difference in the absorption pattern of the light helps us to actually understand what is the, using that as a technique, we can understand what is the tissue oxygenation in the brain. Also cerebral blood flow of the brain. And I think that's the simplest 101 understanding of NIRS. And I think you can have NIRS of the brain, and then you can also do the NIRS of the kidneys, peripheral muscles. I think we don't have much experience using it in peripheral muscles in babies, but I think primarily we use cerebral NIRS. And then we started to use it sparingly, I have to say, not routinely, abdominal NIRS to look at bowel. We don't even use in our center renal NIRS, but that is definitely possible. NICUs across North America seem to be using it. Now, the cerebral oxygenation gradually increases after birth. And generally, it stabilizes over 55 to 85%. The way to understand cerebral oxygenation is if the SCO2 is less than 55, what it essentially tells you is there is increased extraction. If it is more than 85, essentially it tells you this poor extraction. That's the way to understand NEARS numbers. And then we went through this. You have this autoregulatory phase and a passive collapse and passive dilatation phase. And, I think what the whole idea is whether we can pick them up when they are autoregulating themselves. And I think that's the whole point. Now, hypercapnia, acidosis, hypoglycemia, they increase the cerebral blood flow, whereas hypocapnia and hyperoxia, they decrease the cerebral blood flow by increased vasoconstriction. We need to understand that. And I think, again, cerebral NEARS, it helps to trend them. And of course, they nicely come as a trend. And that will give us a better understanding. If you're sitting higher at, say, for example, 75, and suddenly you're trending down over 30 minutes to a lower number, then you want to look at what's happening. And I think that's an important piece. And I'll show you how we use it in our center. It seemed to have good correlation with blood pressure, but it doesn't have good correlation with cardiac output, and that's something to remember. It seemed to have interestingly good correlation with superior vena cava flow. And that's the kind of algorithm that we use to actually primarily we use in preterm babies and in some special situation like HIE. So if you see a decreased NEARS values, then you are looking at a decreased oxygen delivery to the brain or an increased consumption. And then you work through the pathophysiology. Same way, if you have an increased NEARS value, either it is an increased oxygen delivery to the brain or decreased oxygen consumption. Then you work through and what could be the pathophysiology and try and correct that. And I think that's the way we use. And we have a interestingly an integrated way of looking at in the combining blood pressure and the NEARS values, and then coming up with an algorithm to do the next steps. Essentially, it all boils down to you've corrected the CO2, you've corrected the FiO2, you've corrected the hypoglycemia, you still don't have an answer, then go ahead and get a TNE to understand this further. So what I'm essentially telling you here is look at it clinically, look at these trends, then try to understand, try to add TNE to this element, and then try and see what is the systemic blood flow before you go ahead and do the management. So I think I seem to have some more time, so I'll just putting it all together is what I want to talk about. We completed a study looking at multimodal monitoring, essentially using these principles. We randomized babies to existing guideline, which is basically using gestational age as a mean blood pressure and without multimodal monitoring for management. And then we used these principles of multimodal monitoring, including NEARS, TNE, and whatever I laid out here. And then gave hemodynamic opinion to the team to really see whether they will modify treatment. And the primary outcome was what is called the VVR score, which is essentially an inotrope score, number of inotropes and dosages that we use, whether there was any difference. And there were secondary outcomes like major morbidities that we see in the NICU. We couldn't really show any difference in the primary outcome. But interestingly, babies who had multimodal monitoring seem to have a statistically significantly lower incidence of chronic lung disease. So this is in the process of being written up. But I do, of course, during the time, as it always happens when you do RCTs, it's a single center study. People started to use the same principles even for standard protocol. So there was a lot of contamination that happens as well. So I just wanted to do a couple of quiz and then so that we can see how we can put them all together. So maybe I'll stop sharing and I'll go to the
People can log into menti.com.
Yeah. So people can log into Menti. Yes, that would be good. I'm trying to see. Oh, yes. So we can maybe do the same question again. 26-week gestation, 6 hours old, ventilated, 21% oxygen, arterial blood pressure 26/17, mean of 20, urine output is 0.5 ml per kilo per hour, lactate of 0.5 and CFT of 2 seconds. So what would be your management?
Do you want to share the screen, Dr.
Oh,
Kumar?
I haven't. Okay, sorry. Thank you. Thanks for that. Okay, let me just see. Yes. I hope you're able to see my question. And so essentially what we are driving at here is at 6 hours old, there's not going to be much urine output anyway. So 0.5 ml per kilo per hour, is okay. And we wanted to look at, I don't have all the data here, but I think essentially what I'm really hinting at is your lactate is okay, your CFT is okay. Of course, your blood pressure is lower. If you look at the centile charts, perhaps. But I think if you look at the centile charts, they are possibly on the fifth centile on Zubro. So essentially, it could be what is called transitional hypotension. And preterm babies go through this because they've lost the placenta. They don't have that low pressure circuit anymore. So they go for a relative hypotension and they compensate subsequently. As we can see, the majority is going for none of the above, and I think that's possibly the appropriate response. So we can do the next one. So here, this is a 24-week infant who's 6 weeks old, 30 weeks corrected gestation, previously treated duct, small and restrictive, with increased oxygen requirement. Urine output is 0.5 ml per kilo per hour. Lactate is 4. CRT is 2 seconds. Acidosis is -8, base deficit. Blood pressure is 42/18, mean of 26. The fifth centile is 43/21, mean of 28. Cerebral nears is 45%. Left ventricular output is 400 mils per kilo per minute. No PDA, hyperdynamic contraction. So that's the story. It's a 6-week-old with a hyperdynamic contraction, LVO as you see. So my question is, what does the nears value indicate? If people can make a
make a good guess. I mean, we have a whole new session tomorrow.
I know.
We can run this question again tomorrow, then people probably can answer.
Yes, absolutely.
Let people try. Yeah.
Absolutely. I just want people to try this. Don't hesitate. And, so the point I think I wanted to make here is if you have a 45%, it actually says increased extraction. So if you have a higher value, which actually says a decreased cerebral perfusion. So this essentially means increased extraction that's happening here. And the same story. What do you think of the left ventricular output? Is it high, normal, or low? Left ventricular output of 400 mils per kilo per minute. I see a response for high, and I think that's true, and I think left ventricular output is high. So then that kind of makes me ask the next question. If people want to make a guess, based on what you know so far, what is your most plausible diagnosis? Is it a septic shock, cardiac dysfunction, significant PDA, or pulmonary hypertension? Yes, I see that people are going for septic shock, and I think I think that perfectly makes sense here, because it looks as though it's a diastolic hypotension that we are seeing, and we are seeing a hyperdynamic contraction. LVO seems to be in the normal or high normal range, and this baby does not have a PDA. It's because it's small and restrictive, so it's reasonable to say it is a septic shock. So I can skip that, and I have one more question, and then maybe we can finish with that. So this is a 23-week, 2 days old baby who received a dose of ibuprofen. Oxygen requirement is 100%. Saturation is in the mid 80s. Blood pressure is 30 on 20, mean of 23. Fifth centile is 33 on 14, mean of 20. Urine output is 1 ml per kilo per hour. CFT is 2 seconds. Lactate is 2. Acidosis is +3. NIRS is 55%. The TNE shows right ventricular function mildly impaired. Left ventricular output is 160. Right ventricular output is 120 ml per kilo. We haven't really gone through a lot, but I think I kind of briefly spoke about stuff. I don't know if people want to have a go. Essentially, what is happening here? Yes, and I think people are going for the pulmonary hypertension with low systemic flow and RV dysfunction with a normal extraction, and I think that's it. And I think the majority is going there, and I'm really happy we are on the right track, and that's how we put them all together. Okay, and I just wanted to finish my talk with sorry. With acknowledgement for my ZEST group, which is the zonal admin service for TNE, and Ayman Surak, and I think I borrowed heavily from his slides, and I want to thank Alberta Health Services and Strawley Children's Hospital and the Edmonton Zone NICUs for making our service possible, making our studies possible, and to be able to give the talk. Thanks, everybody.
Great. I could see some familiar faces. Joseph Ting is there. I've done some
Oh,
projects.
yeah. Oh, you know him? Okay. Oh, that's
Yeah, we
nice.
worked in Canada together, so I have
Oh,
done
man.
few projects with him.
Okay, good.
Over to you, Shamla, to summarize. Dr. Shamla. So I think while she's turning herself on, a great talk. Absolutely, you summarized everything what we are trying to cover up in this the whole workshop, because I think we will be going in all the individual aspects in the needs and in the non-invasive cardiac output monitor. But I think you have put it in the perspective, and that's how I think our approach should be, and that's what we thought the concept of this workshop also light from basics to advanced, and how you put everything together for a clinical decision making. Excellent. And I think the Mentimeter was really excellent interactive way. Probably you'll try to use it tomorrow as well.
Yes. Great. Thank you.
So very engaging sessions. Some of the questions we try engage answering. Sanoj, before we start, we have a couple of minutes. We full 1 hour of Dr. Kumaran. We
Sure.
had 5 more minutes for him. Is measuring SPC flow part of targeted echo teaching? We need a cardiologist to measure.
Yeah.
That's the question, I think. Yeah.
Yes. So what is happening is, I think cardiologists don't, but they're not interested in SVC flow. I have to say, it's mainly neonatologists who are trained in doing targeted neonatal echocardiography. They are the ones, I think, who are looking at it. Yes, I think we measure SVC flow as a part of functional echocardiography or targeted neonatal echocardiography. As I said, any of these things, they have their fallacies and they have their unreliabilities. We put them all in context and trend them. And I think, don't use those numbers. Just trending those numbers is the most important thing for anything, Yeah, absolutely,
Perfect. Lots of positive. Thank you, Dr. Irfan, Prashant, for engaging sessions. So yeah, I mean, SVC flow, again, in Australia, when we were using a lot, now we are using it less, more so in preterm, we are trying to use it more than the term population. Because
Absolutely.
I think SVC probably, like the cardiac output measurements are more useful. But yes, I mean, and plus for good academic and research interest also with SVC flow.
Yes, it is mainly, I think its role is mainly research interest, but I think we try to trend them, and I think we do them anyway, so that we can trend them and I think see if we can make sense out of it. But I do think that increasingly the reliability is being questioned. I think we'll see how this whole thing pans out,
Yeah, I quite like that consultation including. So maybe if possible tomorrow we can have a 10 minutes at the end go through that algorithm of consultation, with the case. How do you
Yeah.
come to conclusion when we finished all the talks? Maybe I think that was something to good recap,
Yeah.
correlating all things together. So I think that was a very good algorithm to utilize in the unit.
Good.
Looks like no more questions, so we will move on to the next talk. Thank you, Dr.
Thank
Kumar.
you. Thanks, everyone.
Excellent
Thanks.
session. Thank you for your
Thank you.
time.
Thank you.
All right, so we move to the next speaker. I'll just pull up the slide. So the next speaker is Dr. Sanoj Ali, my dear friend and colleague from previous unit. He's attending physician of neonatology in Sidra Medicine, Qatar. He's also program leader for quality and safety. And he also has got a wide clinical experience ranging from Australia and different places. And I know him personally also, but he's very academic and pro and a lot of interest in hemodynamics, a wider interest in hemodynamics, respiratory, monitoring quality and safety. And today he'll be talking to us on the how we utilize the basic pulse oximeter and the trends of the oximeter for various indications, and specifically focusing on the preterm population and how to prevent ROPs and everything related to that. So over to you, Dr. Sanoj. You can share the slides.
Hi, thanks, Kiran. I hope you can hear me clearly and you can see my slides.
Absolutely, yes. And
Great opportunity to present here. Thank you, Dr. Kiran and Dr. Shamla. And I am, although I'm working in Qatar right now, I'm visiting my parents. I'm speaking from a small village in Kerala, so this is going to be a test of the internet connectivity and stability, and hope it lasts for the entire next half an hour, which I'll be covering. Just for full disclosure, with regarding to this talk, I was a part of a team that developed an oxygen control algorithm, which is incorporated in the Oxygenie ventilator and the SLE 6000. But I won't be talking, of course, it'll be a part of my talk, but I'll try to be as unbiased as possible. So I would also, I'd like to start off by acknowledging I trained in Australia for 12 years before coming to Qatar, and we had a great research team that includes engineers and medics. And so we, like everything in neonatology, you need a good acronym like trials. And we used to call ourselves a Gremlins, a group of engineers and medics laboriously investigating neonatal systems. So, and Peter Dargaville, he was our lead. I know many of you in the neonatal world would know Peter Dargaville. This was him during a visit to Qatar recently, where I managed to take him around to some of the interesting sites. He's been my research mentor, and I would like to acknowledge his significant contribution to many of the slides and studies that we're presenting today. So just a brief outline of the talk. So we'll be talking about what is a challenge with regard to oxygen therapy. We all know oxygen is both a boon and a poison. So we really need to kind of find the right balance. It's like the Goldilocks, if you remember the old, story, Goldilocks and Three Bears. Too much or too little of anything is not good. You should find the right mix. We have to acknowledge that oxygen therapy, especially in preterm, is a very difficult biological system to control, and inherently manual control of oxygen is actually is doomed to fail. Sorry to start off on a very pessimistic note, but I'm sure all of you have struggled, especially nurses at the bedside. You would acknowledge how difficult it is to try and maintain a preterm baby, especially one who's evolving chronic lung disease. They really fluctuate with their SAT so much, especially when they have a PDA and so forth. And some of the solutions we'll be talking about. We'll be talking about how can we optimize manual titration of oxygen, FiO2. We're talking a bit of the basics of automated oxygen control and performance of various algorithms. And then, and especially with regard to automated oxygen control in preterm infants, some of the practical issues, outstanding questions, and very important, I think we should be looking at what is the applicability in low and middle income countries. So I hope we can try and, you notice that, I'm not, there are some other topics that will be covered in the workshop with regards to trend monitoring and oxygen saturation index. But I thought automated oxygen control is something that may not be very familiar with everyone. And I thought it'd be a good taster to cover that during this pre-workshop online session. So when you look at these are data from various WHO sources. So 13 million infants are born preterm in the, every year. And that is by pure definition, anyone born before 37 weeks gestation. But out of that, 1/3 of them require oxygen, and the deaths are quite significant. Nearly 1 million babies die every year who are born preterm, and close to, depending upon where facilities are available, 0.2 to 1.2 million have ROP requiring treatment out of this 4.5 million. And we do know that this, it's very difficult to target the ideal SpO2 range. Too little oxygen hypoxia results in increased risk of mortality and necrotizing enterocolitis. And too much oxygen, of course, we know results in ROP and bronchopulmonary dysplasia from the various reactive oxidative species. And even very specifically, hypoxic episodes, episodes of prolonged hypoxia associated with ROP and adverse neurodevelopmental outcome. And so does hyperoxic episodes with an increased risk of ROP there. This is a very interesting slide, which is, I used to use this a lot, but it's been around for a while. This study from the Children's Hospital of Philadelphia, from the group of Alan Flake, who's a world-renowned fetal surgeon. They kind of tried to create this concept of an artificial womb, whereby they actually exteriorized a preterm lamb equivalent to a 23 to 24 week gestation, a newborn baby. And what they essentially did was trying to create a artificial placenta or artificial womb with with amniotic fluid, and almost used what you could call the same concept of ECMO, cannulating the umbilical vessels and using an ECMO kind of circuit to grow the baby. And what they did is, over a period of nearly 4 to 6 weeks, they managed to, even the lamb, the preterm lamb actually even managed to grow wool at a stage. So, and this concept, which was first published in 2017, now we have progressed to such a stage, and there are multiple studies going around in Australia, Japan, and other centers in the US. But the group in Philadelphia are almost ready. They're awaiting FDA approvals for the first trials. So you can imagine this is trying to, no matter how hard we try, it's very hard to mimic Mother Nature. And, whatever, even the most gentlest form of ventilation, we do cause injury, we do cause fluctuation, oxygenation. So this might be the future. Us neonatologists might be out of a job pretty soon, but I guess this will be applicable to, at least in the initial stages, to a very small subgroup of infants, especially in the 22 to 23 weeks gestation ones, where the outcomes would be otherwise quite poor. But watch this space. This is a study called the SNOOT study from my old unit in Hobart, Australia, where nearly 5,000 hours of recordings of preterm infants on oxygen support was taken. And this was just manual control of oxygen therapy. And you can see at that time in 2014, this was the target range used in the units of 88 to 92% in the grayed out zones. Of course, nowadays, most units have moved on to 91 to 95 after the boost studies and so forth. But you can see that only 31% of the time could the bedside staff keep the babies in the target range, which was recommended at that time. So it's quite a challenging, nearly 1/3 was above and a further 1/3 was below. And this is, apologies for small print. This is just, I just want to, when I came to Qatar, this was quite a challenge in a new unit. So this is a brand new greenfield NICU, which had just opened, had staff from 80 different countries. And everyone had different ideas about what the target ranges should be, what the monitor alarm limits should be. And we had a couple of sentinel events where we had a retinopathy of prematurity resulting in retinal detachment and blindness, which was really quite upsetting. So we created a QI project. So this is just a poster that we presented at the recent Pediatric Academic Societies in Toronto. But I want to go into detail with some of the interventions we did. The first thing we realized from an initial survey was that every staff in our NICU who had come from various countries had a different idea what the optimal SATS target would be. So we did a literature search. We said 91 to 95 or 90 to 94 was the accepted SATS limits across most NICUs around the world. So we created this project called the Oxygen with Love project, and we had these little laminated cards put at all bedsides below the monitor. So we said, and we just wanted to keep it as simple. We didn't want to have a gestation cutoff. We said any baby admitted in our unit, if they are on oxygen, this is what their alarm limits target would be, 91 to 95. If they were more than, and this is what you try and aim for. But of course, the monitor alarm limits, if they were in room A, would be 91 to 100. And if they were on more than 21%, we would keep the same monitor alarm limit. Very pragmatic decision. We said we don't want to make it too complicated. You would notice in other units, they try to keep the alarm limits a bit more wider to prevent alarm fatigue for the nurses, and they might choose 89 to 97, 1 or 2% above. And then we also had a specified target for babies, especially when they had PPHN or cardiac disease. We could have specific bespoke targets. So this was the first thing we did in phase 1. And that was quite easy to implement. In phase 2, we tried an oxygen titration guide. Every nurse had a different way of adjusting the FiO2. So we said, let's just standardize it in a way and see what we do. And this is just a card. We created another Hoot kind of checklist to see, make sure that, the ECG correlates the pulse oximeter, make sure the patient is, the appropriate signal is there, rule out obstruction and so forth. And then the third thing we did was we started using the histogram. We have a Philips monitor in our unit, which has a histogram that comes up at the push of a button. We had these limits already pre-programmed, so 91 to 95, so you could really see how much. So in this instance, 75% was the time spent in the target range for over a 4-hour period. And then there's 10% above and 15% below, which we thought was quite good for a preterm baby. And this can be adjusted for an 8-hour period and 24-hour period. So this histogram data was quite useful. This is a very objective way of quantifying the targeting for the infant. And then subsequently, we developed a histogram tracker, which is so that we could see the longitudinal trends. And this has been subsequently incorporated into the electronic medical records, which the nurses religiously document. So these were all, I think the overall, just with, so pre-intervention, we did some trends about, so this in red you see is the time in target range. So our baseline was 49% of the time was spent within the target range of 91 to 95. And the correct percentage alarm set was only 12%. And after phase 1, after we introduced the alarm limit cards, bedside alarm, percentage of alarm limits was quite high, 93, if you can see in the 4th column. And then you can see that, there was an improvement in target range. And it was a constant PDSA cycle. So the second phase was introduction of oxygen titration guide. There's a further improvement. And subsequently is using the histogram in phase 3 and B. And you can see that, despite our best efforts with a manual oxygen, with enhanced manual oxygen titration, we still were only achieving around 59 to 60% within target range. So this is when we decided we had to do something more. We'd probably reach a ceiling. And I'd be really interested to hear, if any of the other colleagues on the chat group, what your experience with this enhanced manual oxygen titration is. So we decided we need automation out here. And so let's look into a few of the basics of automated oxygen control. It's when you look at it, it's fairly simple. So we have a set of SpO2 readings going from the oximeter, and it goes up to a regular intervals up to 1 second. And it goes into a control device, which is which houses the algorithm. And subsequently, the algorithm tries to target the midpoint. So if our SAS target is 91 to 95, it always tries to keep the baby SAS within the 93%, so that it keeps on constantly adjusting the FiO2 second by second. And subsequently, we have an FiO2 response. And you think that this concept is not very alien. For those of you who are familiar with the newer technologies in our cars, the radar cruise control and all works on the same technology. And if you want to look at a diagram, this is what happens. We have the baby, the pulse oximeter connected to the baby gives the data. We have a lovely nurse at the bedside who looks at this data and adjusts the FiO2 on the ventilator or on a standalone oxygen blender. And this is what is delivered to the baby. And if you look at what automated oxygen control is, all you do is substitute the nurse with an algorithm which is housed within the ventilator or connected to the blender. And but of course, the same caveat applies. You always need a bedside staff to supervise this and not leave everything to the automated control algorithm. But there are some pitfalls of automation, like with anything else. So this is if you look at these 4 graphs out here, with the x-axis you have the SpO2 and on the y-axis the time. This is if you don't adjust the FiO2, which is on the lower bar out here, the SpO2 in black fluctuates and doesn't stay within the target range. But if you have an algorithm which is overpowered, and this is what results in, you get this fluctuation, you get this significant, the FiO2 goes up and down, the SpO2 fluctuates accordingly, and that can be quite dangerous. And the last graph, that is graph D, is when you find that, this is an adapted algorithm, so that you can see that there are fine adjustments to the FiO2 happening below, and then the SpO2 in the SpO2 out here on the top stays within target range most of the time. This is what we'd ideally like to see. you can see that there's lots of new ventilators available with, the Avia ventilator had the Clio algorithm from Miami. But most recently, there are many ventilators. The CLAC option Leone, the Preco and Fabian, Oxygene in SLE, and the Spock on the Stefan ventilators. And what you'll notice out here, the algorithm type. So the rule-based algorithm is a fairly basic algorithm. If the algorithm senses the SpO2 comes down from 90 to 85, it increases by a proportional amount to 3 or 5%, what we talked about in the manual oxygen titration card previously. But the PID algorithm, what you can see in the Oxygene and the Spock, that is what is probably the most effective ones. And we'll talk about that a bit more, what PID means. So PID stands for proportional, integral, and derivative. Proportional term is a coefficient which corrects the current state of error. That is, it corrects the difference between the current and desired SpO2. This is in very simplistic terms. The mathematician can go into all the various coefficients, what it looks like. The integral is a sum of cumulative errors, so it remembers the past errors and stabilizes the system. Whereas a derivative tries to predict future errors and tries to prevent overshoot. So all these three systems act in concert to try and keep the baby within the normal SpO2 target range. And this is a graph that, this is a chart that compares all the various algorithms and the various studies that are available in literature. I've highlighted Oxygene in a way that is just because that is the one that is most familiar to me. And if you look at the black graph, is the percentage of time present, the baby spent in the target range in the manual control, and the white stands for in the automated control. So you can see in almost every study, automated oxygen control did better than manual control. And if you look at certain studies, the difference, in percentage varied, it's as high as 31% in a study by Reynolds et al. And the difference was fairly low in some other studies. But what I want to stress out here, this is not comparing apples with apples. If you look at these studies, some of these studies are only babies of non-invasive oxygen, non-invasive support, some are really on ventilated babies. If you look at the target range in the bottom of the x-axis, you can see all the target ranges differ quite significantly. And so it's not an absolute direct comparison, but this is just to give you a flavor that almost in every instance, automated oxygen control appears better. And you have the most recent meta-analysis by Stafford et al. Published in 2023. Again, overall, from all the studies, automated oxygen control, at least it offers improved time spent in the SpO2 target range. And I just want to go into a few more details about some of the initial studies we did in Hobart using the VDL1 algorithm, which is a basic algorithm, and the VDL 1.1 was the one with the adaptations included in it. So this was a really interesting study. We had a medical student at the bedside. This is when we didn't really trust the algorithm enough. So they were connected this is a crossover study, 4 hours. We just measured the manual control, and then 4 hours, a medical student spent the time at the bedside of the research laptop and looked at how the algorithm functioned. And then 4 hours later, we had a flanking period of automated manual control. And it showed that manual control is better. Then once we trusted the algorithm a bit better, we did a 24-hour crossover study. And this time we left it we didn't have a person watching it. We left the algorithm to do his job. And what it showed was, again, the time and target range was significantly better, as I said, almost a 20% difference. If you look at the box plot of the white graph and the purple. And what is more importantly, of the 20 patients, every single baby, this is black is the time in target range for manual control, and white is with automated oxygen control. Every single patient, there was an improvement. Of course, the improvement varied based on what the baseline stats were, but every patient did better on automated oxygen control. And if you look at the nursing workload, there was a reduction in the need for manual adjustment. It is almost analogous to volume guarantee that you see in most modern ventilators. And I think all of us trust volume guarantee right now. And I hope in the future, the nursing staff and the medical staff will learn to trust the automated oxygen control. And what a study from Brisbane also showed, that when they did the mathematics around it, the automated oxygen control, by reducing the number of adjustments and the need for manual adjustments, almost reduce 1 nursing hour per shift, which is quite a significant reduction in their workload. And also, it's not only just the total time spent in the target range. You should also look at the episodes of severe hypoxia and hyperoxia for 30 seconds, 60 seconds. These are almost, especially the 60-second episodes of hypoxia and hyperoxia have almost reduced to zero. And that was a significant, has a significant clinical impact, I feel. So we said that, okay, in all these crossover studies, there seems to be an improvement. What about, comparing two devices in a randomized crossover trial? So this is Oxygenie and Clio. There's a unit in Leiden, which was one of the early adopters of the automated oxygen control. So they use the Clio algorithm, the VIA. But this is again not a direct, but there was some difference in the time. There was improved time in targeting in the Oxygenie algorithm compared to the Clio. But what is most important to note is that there was almost quite a significant difference in the time below target range. So it was trying to correct hyperoxia, but inadvertently it led to a slightly more time spent in below the target range. So that is something we should be aware of. So don't just look at one number alone. You should also look at there should be a proportional reduction both in time spent above and below the target range. So again, just a word of caution out there. And what about the clinical effects of automated? So we all know that it improves the time in targeting. You have to ask the question, so what? Does it affect important clinical outcomes like mortality, ROP, NEC, BPD, and severe IVH we worry about? And this is quite interesting. This was again a cohort study when before and after implementation of the Clio ventilator, and again in Leiden, it showed no difference in any of the important clinical outcomes. But again, this is a cohort. This is not a direct comparison. This was a pre and post implementation of automated oxygen control. But and again, subsequently they changed from the Clio algorithm to Oxygenie. And in these two cohorts, also no major difference apart from slightly less treated ROP with laser in the Oxygenie cohort. So again, these are still early evidence of data coming through. And now the most, I think, if you want to look at long-term outcome, there is a study called the FIO2C study coming from Germany. This is a randomized control study, which hope to enroll nearly 2,000 infants, and this is a study protocol. And they want to look at, as soon as the baby was born in the first 72 hours, they would be randomized to go into either automated or manual oxygen control. And the hope was to keep them on this support throughout their stay in NICU, and then look at important clinically relevant outcomes. But as of now, what we heard that because of difficulty in enrolling for the study, they have stopped the study at nearly just half of the initial recruitment. And we should be having some of the initial in-hospital outcomes close to the end of the year. So I think that's really important evidence that we should be looking out for. And automated oxygen control at birth is again quite difficult. So people might ask, what does it matter in the first 10 minutes of life? Is it really important to really target SpO2? But actually, there are studies that show that if you're not exposed to, if you're not in the target range in the first 10 minutes of life, there's increased, especially with hyperoxic, there are high incidence of oxygen-free radical metabolites and everything in some babies. So this is a study that was, this is probably the only human study done so far using automated oxygen control at birth, again, done at my old unit in Hobart. And this is again, two cohorts. We initially had 20 babies where we checked the manual control of oxygen and subsequently we implemented the automated oxygen control arm. And again, no major difference in terms of time spent in target range, although this is only 20 and 19 babies each. But most importantly, it showed that there was a significant difference in the FI2 adjustments, and no manual adjustments were required in the manual control arm. And at the same time, the clinicians had to adjust almost 11 to 12 times for a baby, for each baby in the automated oxygen, in the manual control. So in the automated oxygen control arm, there was no manual adjustments required. So I think if you look at it pragmatically, you're doing so many things while resuscitating a baby, intubating, putting lines trying to stimulate the baby. The last thing, if you can have a machine that can do the job and automatically adjust the oxygen, that will be of great benefit. And these are a few examples of some recordings we did. So the purple traces is the SpO2 and the orange trace is the FI2 adjustments. And you have the dotted lines is the escalating SpO2 targets for a baby in the first 10 minutes of life. And you can see that every baby behaves quite differently. This was the automated oxygen control. It shot up and the initial SATs were quite low. The SpO2 was boosted up, and then subsequently, once the SpO2 became above the target range, it tried to adjust and go down. And there are some babies where you actually does a beautiful job, but you would argue that this baby would have done reasonably well with manual adjustment alone. And the third graph is a really poor control. The FI2 and the SpO2 is widely swinging, which is not a great thing. So some really again, it's not fit for every baby, but we hope that with improved adaptation, this can be better. Lastly, I just want to touch upon, the importance of these premature babies who are born in low and middle income countries. They really, especially newborns, they form a significant proportion of 50% of deaths of children who die below 5 years of age, and it's mostly in the first week of life, and majority are due to respiratory distress syndrome. So it's really important that all this technology, we have all these fancy ventilators. So this is a blender that we use. We just convert a normal blender with a actuator, with you can see out there, and then this technology, once it was studied, went into the SLE. This is the 1500 as a standalone blender, which can be connected to any oxygen source. And then we have it housed in the more expensive ventilators. But our same group out here in Hobart, in Australia, we kind of did a study, and this is a really nice collaborator. It's called the Universal Safe Oxygen for Newborns Collaborative, the Unison Consortium. And we're really trying to make sure that this technology can be delivered to the needy children in less developed countries. So this was in sub-Saharan Africa, in Nigeria, and Uganda. They did the study called the Oxymate study, which has recently been published. It did show, again, they rigged up a CPAP device with a very basic rudimentary oxygen blend, with a automated oxygenation control. And it did show significant improvement in oxygenation outcomes, reduction in oxygen exposure, and the average FiO2. And there was a possible link with reduction in the duration of CPAP. And you can imagine in these, we are used to, 1:2 nursing workload for babies on respiratory support, or 1:1 for ventilated babies. But in the low and middle income countries, the nursing ratio could be 1:20 even. So it's really important. Automation can have a significant impact out there. So in summary, what I can tell you about automated oxygen control in the NICU is that it's well studied clinically. It improves time and target range compared to manual control of FiO2, which I would honestly say lacks precision and finesse, and has been proven in many studies. There is less severe hypoxia and hyperoxia. It does save nursing time. The clinical benefits are uncertain, but I would say that it can be cautiously recommended based on at least time and improved SpO2 target range, and seen in all studies. But for long-term benefits, we still need to await the evidence. And there are multiple options available in various commercial ventilators, and the use in the delivery room settings warrants further assessment. So future directions, as I said, rigorously conduct RCTs of automated oxygen control with relevant outcomes, and you can have further enhancements and individualization of algorithm performance. And also really important to make sure that this technology doesn't just stay with, in the developed world, but it goes into the low and middle income countries where a significant proportion of preterm infants are born. And this could be the future NICU staff. It could be all cyborgs, half human, half robots. But I'll leave it on that. I hope I stayed on time, and happy to answer any questions. Thank you.
Perfect, Sanuj. Excellent. Already lots of good comments are flowing already. I think this is a new concept for many who have not used automated FiO2 control, and that was the idea of introducing this topic in today's session, because I think pulse oximeter everyone is using. What I think we are lacking is the smart pulse oximeter and smart multipara monitors. And plus, I think even increasing awareness of the smart features available in the multipara monitor, like the trends, how we can manipulate those trends, as you briefly showed. Like in your unit, you have that setting of 0 to 95, and you can actually see what is the percentage of the time baby is actually maintaining the saturation in the target range. And I think in India, that is where the problem is. The oxygen is used in uncontrolled way in many center. I'm not like generalizing in India. Obviously, lots of centers are doing excellent work, but as you rightly mentioned, wherever there is a poor nursing ratio, 20:1, or one baby, one unit is just governed by the one nurse. There, I think this all monitoring and tight oxygen control is not happening, and the tendency generally to increase oxygen level and increase the sats level, so that baby doesn't desat. So there is often over oxygenation which is happening. Although in your study, I think you showed that the clinical did better than the actual machines, but that again holds true for 1:1 nursing. So again, wherever there is a issue with poor nursing ratio, the automated FiO2 control might be the future, isn't it? So I think very, very important, valid point you pointed out, and that again, one question which I wanted to point out is how you apply this to a manual blender, and you showed that your the study which you mentioned. So can you just explain again? Can we have the device which can be plugged into the normal blenders, which can be useful in the LMICs, where the control is uncontrolled. So can you explain how it actually works? Yeah,
Yeah,
this.
so I don't know. So this one, this is a standalone device which doesn't need to be connected to a ventilator. All it needs is an oxygen blender to be connected to it. So any baby on bubble CPAP, you can use this device and have the connection. So this is probably more cheaper and more cost effective than having a full vent. So this then the full ventilator SLE 6000, which of course does HFOV and conventional everything. And this one, the Santobi automated blender, this is actually, it's not commercially available. It was a rigged up device done by the engineers in our research group who managed to kind of just, create these little, if you can see, it's a fairly crude thing, but this was connected to a laptop which housed the algorithm, and it was able to adjust and it's very funny. You could actually see this blender dial moving based on the FiO2, SpO2 requirements. So the SpO2 of the baby and the FiO2 is adjusted. And this Oxymate device, this is actually quite interesting. This is what was used in the study in sub-Saharan Africa. I think it is a collaboration between the research group. I think there's already a device which delivered a slow flow oxygen and CPAP that is available in certain units out there, and they rigged it. So watch this space. Because the study has shown effect, has had a positive outcome, this might be commercially available soon. And I'm sure, in India, it's only a matter of time before some of these more cost-effective devices are available. And I think the evidence is showing that if we do, it does, as I said before, we don't have long-term outcome benefits yet, but it makes physiological sense or intuitive sense that, if babies spend more time within the target range, less exposure to hypoxia and hyperoxia, you would expect these babies to do better, but we need the evidence, the trial evidence to come through for that, yeah.
So again, great. I mean, one more question was, so I mean, I think we need those automated FR2 controls in India for sure in the larger units. And I think many of our centers will be happy to trial those out. We have many attendees who are even heads of the big units, and they would definitely would love to trial these devices if they're made commercially available or under trial also. That is something to look forward. One question was, what currently available in Indian market, SLE 6000 is available, and they come up with oxygeny this thing. And we do have, I mean, currently in our unit also we have oxygeny in this, and in the workshop we will be demonstrating all how it works. All the demonstration will be done. We have SLE 6000 coming in with a automated FIOT control. But apart from the preterm, so what I think currently we are using this for even PPHN babies. So what we are doing, the pre-ductal, we are connecting to the oxygeny, and post-ductal, we are connecting to the multipara. So automatically, the ventilator is adjusting as per the pre-ductal. And that is something I think we are trying. I mean, there's no evidence backing it up, but as a practical, it really working, helping us to wean the FiO2. But obviously, still need a good governance because some of these babies fluctuate a lot. But I think especially in PPHN, we are able to observe, and again, ventilated preterms, this is where we are trying to use more so in with this SLE 6000. One question was about alarm limits. Again, sorry, Anish, just going over because this is a very interesting and common basic topic. So I thought we can just spend a couple of more minutes. Somebody asked about target setting the target or alarm targets. Dr. Tariq, how to manage the alarms, and if it is outside the range, you need to go and check all the time. So how do you manage the alarm? How you set also, if you can explain, yeah.
Yeah, it's a very, very important question. And again, Kiran, and to all the delegates attending, I'm really not, I put an SLE 6000 out here because that is something that is familiar to me, but I'm not advocating for this is the algorithm to use at all. It is just that this is and if you look at all, I'm just saying in general, automated oxygen control, be it every algorithm, it does seem to work, and it's too early to say which one is better than the other. But based on the evidence, this is what is available in India, I know, and it seems to be doing the job. And there are various options. Not many ventilator companies have the non-invasive option or a more cheaper option. So that is something to highlight out here. Again, so please don't mistake that I'm actually vouching for this at all. The question to the alarm limits, it's very, so we, in our study or in our unit, we did we have 180 nurses, a 54-bedded NICU. Very difficult to be too complex about it. So we said, this is a 91 to 95 as a SAS target we're going to choose for our unit. And we're going to use the same 91 to 95 as the alarm limits we set on the monitor. There is both good and bad. Of course, with 91 to 95 as the alarm limit also, you think that you'll get tighter control and they'll be more proactive with it. But the corollary is that it'll lead to nursing alarm fatigue, because especially, if the baby is swinging a lot. So some units have taken a pragmatic approach. They go one above and one below the target range. So they put the alarm limits as 91 to 96 or even 89 to 96. And we should educate the nurses that, not to chase the SpO2 too much, because you have to understand, if you make a change in the FiO2, the amount of time it takes for that change to reach to get into the baby's lungs, to be absorbed into the bloodstream, and then to be reflected on in the pulse oximeter, it takes around 30 seconds to 1 minute. So we should also educate our staff that once you make a change, you have to wait for some time to actually for the SpO2 to reflect that change you made in the FiO2. So those are some things to with bedside education, but it's really important to get your nursing staff on board. And we do something called a safety check for all the nursing staff every shift, that before they get onto the baby, they should check the alarm limits on the monitor. They should make sure it's all according to guidelines. But it's a work in progress, always a challenge. And but as I said, the recommendation what we do is different. But in generally in the literature, they recommend at least one or 2 percentage points above and below the desired target range for the benefit of nursing workload and for preventing alarm fatigue is what they set on the bedside monitors. I hope that answered the question, and that
Sure,
is
yeah.
what Dr. Tariq was looking at. Yeah.
I hope so. And again, in the workshop, probably we'll show those alarm limits specifically, what you do it, and the bedside, what you can put it for the various gestation. Again, PPHN is one where again you try to target the saturations. One question I think you've already answered, but just running the a non-invasive and CPAP also you can use, right? You just need a right ventilator, whether it can be used for
Yes.
yeah.
Exactly. I mean, many of the ventilators that have this algorithm have the non-invasive support option. But as I said, there is the standalone blenders, devices that come, which can be connected to any non-invasive support devices also. And just for that alarm limits, there are some units beyond 36 weeks, they target a higher SpO2 target range like 92 to 96 also. But sometimes for simplicity, keeping 91 to 95 is fairly okay. But we can discuss all those to the in detail in the workshop. Apologies, because we already run short of time. I'm not elaborating further. Thanks.
Thanks a lot. Thank you, Sanuj. Excellent session. I think everyone loved it. New concept. Yeah, excellently covered.
Thank you.
Right
Thank
comment.
you so much.
Read
Thank
the
you.
comments in the box. Thank you. Thank you for your time and enlightening us. Okay. You can stop sharing your slides, Sanuj. Yeah. Dr. Shamla, I'll be sharing the next speaker, and over to you to. Oops, sorry, something else I have covered. Yeah.
Very absorbing talks. So I think, Kiran, are you doing a talk after this, or you're moving yours to tomorrow?
I think to tomorrow. I think it's a long session today. This one also will take some 30-40 minutes. So we'll go till 10 o'clock anyway.
Okay.
So, yeah, I think this will be the last session probably. Yeah.
Okay. So welcome to Anish Pillai, the last speaker for today. Anish has done a fellowship in neonatal perinatal medicine and also in neonatal nutrition. He's a lead consultant at Motherhood Hospital, Navi Mumbai, in neonatology and pediatrics. He did his neonatal training in Vancouver. He's also very academic with multiple publications and has had experience all over. So he's going to tell us about monitoring and trends in neonatal transport. Over to you, Anish.
Thank you, ma'am, for the kind introduction. And good evening, everyone. Thanks for waiting by in this evening. All the talks have been so far very good, so I'll try to keep up the pace. So my slides are visible. Everything is okay?
Sure.
Yeah. So, what I'll be discussing today is how do we ensure a safe transport? And I will come back to some specific situations. And, in our Indian scenario, we have a lot of fears that we can't do a transport as good as the nets or, what is happening in North America. So let us see what is available here, what we can do, and, what all is not available so that we can sort of, figure out the best case scenario. So transport, in neonatal world is inevitable, because we still have a lot of non-institutional births. Almost more than 10% of births in India still happening at home, and also at some lower facilities where, there is not enough services available, like not at a tertiary care center. And there are some differences compared to developed countries that are there in India. Like the transport system in India is non-centralized. If I want to get a baby, from say any part of Mumbai or Maharashtra, there is no central helpline that the patients can call to. The protocols differ from unit to unit. So hospital A, B, depending on the setup, government setup, private setup, they can have their own protocol. The team structure also differs. Sometimes it could be a nurse going, sometimes it could be an RMO who's, not a non-medical person. Lot of transports in India still are a relatively short distance in terms of numbers. Like there are not as many air transports that happen here as compared to the Western world. And the vehicle and technology also can vary. There is a lot of, the Indian word called jugaad, where we would create a small van into an ambulance, or, practically any vehicle can be converted into an ambulance. So there are no checks that are constantly happening. So I'll be sharing a little bit of evidence and a little bit of personal experience from, the 4 to 5 centers that I worked in. And my neonatal journey started in KIMS, where I did my neonatology 3-year training. After that, 3 more years in Vancouver, BC Children's Hospital. And then in a very busy center in Mumbai, till my current center in Navi Mumbai. And again, being a private setup, I still, go on transports. So if there's a very sick baby, there is need for cooling, something very unusual, the consultant goes. So there is no dedicated, transport team like a paramedical team in India, as compared to the West. So the scenarios in India are very variable. Sometimes the family just brings in the baby from home. It could be in a car, it could be in a rickshaw. They could run to the, ER. That could be like one, transport. Some of the transports happen in an ambulance, but majority of the time that ambulance, whenever they are called 108 or whatever number, it is usually just a driver and a semi-trained personnel, specifically not trained in newborns. Then there could be some partly trained doctors like adult physicians, somebody with alternative medicine degrees. Sometimes the stabilization even happens when, we get a call and the GP sort of doing ambu till our transport team reaches, or the obstetrician anesthetist combination is trying to stabilize or hold on to the situation. Or there could be a neonatal physician-led transport team, which probably, would be a better scenario, where a neonatal fellow or a neonatal resident trainee goes with a neonatal nurse. And probably the best case scenario would be that, they call us beforehand saying that the mother can't be shifted, but there is a 25, 26-weeker delivery happening. Why don't you send your team who can attend the delivery and stabilize the baby and then transport the baby back? So all these scenarios, we have faced in the last many years in terms of transport situation in India. So why is transport an extra problem? Like what is the, extra concerns that can happen? So there is a lot of vibration shock, the baby is lifted from one scenario to the other. So that can cause a definite worsening of clinical status. There is difficulty in monitoring the lighting inside the ambulance. The movement artifacts can happen, so the monitor readings may not be reliable. So monitoring becomes difficult. Even the access to the baby is difficult. So even in the best ambulances, you can access the baby only from one side, either the right side or the left side, because on the other side, there is the wall of the ambulance, the one side. So there is only access from one side. The baby is inside the incubator. So procedures like IV cannulation and intubation become extremely difficult. And there are limited options. There is no option for doing an X-ray. Blood tests, some are now available, but not routinely something that you want to do during a transport. So that is why transport becomes an altogether challenging. You are like a 1-man or a 2-man army in the full situation. So coming to ensuring safety, which is the main crux of the talk. So how do you ensure safety during the transport? The first component of transport, which is probably the most important, is the human resource. So like I briefly mentioned, it could be a pediatrician, ideally a neonatal physician plus a nurse with an additional driver, helper, to move around things. Team training and expertise is very important. So even now, when there is a transport call, I sort of have to filter in my head, okay, this is a 24-weeker, so this person goes, or a 32-weeker, so this people can manage. So there is a lot of, troubleshooting in terms of that involved, in terms of deciding who is experienced enough or trained. And they should ideally at least be trained in advanced NRP and some basic procedures like a needle decompression in case of a pneumothorax, inserting a peripheral IV line if needed, and so forth. And lot of data has said that non-physician teams actually reach faster and they get the baby back earlier. So that is also a consideration. Again, these are studies mainly in the Western world where they have like a dedicated transport team who are always ready to take their bags and run for the call. Coming to the vehicle, the 3-4 most important things in the vehicle are there should be a power source with machines having some battery backup, sufficient number of adapters for your syringe pumps and all the equipment. There should be a gas source adequate with extra cylinders. And ideally, there should also be, air cylinders, not only oxygen cylinders, because otherwise blending won't happen. And the vehicle should be big and, it should have some shock absorbing properties. There should be minimum vibration and noise. So it should be a sturdy vehicle. And then you need some good technology. So most important, what we have seen in our Indian roads is that the monitor keeps falling down if it is not secured, or, something will fall down. The baby will be, constantly bumping. So the baby should also be well secured and fastened. All the equipment should be well secured. There should be a transport incubator, transport ventilator, a multi-para monitor, a suction system, and adequate syringe and infusion pumps. So this, what you can see on the right side is, as you can see, it looks very bulky and heavy, but there is this is sort of an all incorporated system. You can see that there is a incubator, there are 3 syringe pumps. In case the transport ventilator on the right doesn't work, there is a neopuff right above to, give manual breaths. And there are, this is the ventilator with respiratory function monitoring, and there are a couple of other monitors below. There is an extra humidifier as well down. So how much can you carry? How much will fit in the ambulance? There are a lot of practical considerations to that. But let us see what could be, the best case scenario in our Indian setting. So once, I'll skip through these slides a little quickly because that is not the crux of the talk. But during a transport, assessment is predominantly important. It should be objective and quick. It can't be a half an hour assessment or a, 30-minute assessment. It has to be 3 to 5 minutes. And there are various mnemonics that you can use. Stable, stops. So S stands for sugar, temperature, artificial breathing, blood pressure, which is perfusion, laboratory works, and emotional support for the family. So a quick checklist will, help to reduce your time once you reach the center. So just go through the stable checklist, make sure everything is in place before you leave the, the referring hospital, and prioritize what needs urgent attention. So even in this table, sometimes the sugar might be more critical, or sometimes the breathing might be more critical, sometimes the perfusion. So just prioritize and sort of tackle each and everything so that the baby stabilizes very fast. And always think about the local resources and manpower. So if I go to transport a very sick baby, in the referring hospital, I know that there is a referring pediatrician, they have their nurses, they have an X-ray if I need to. So troubleshooting what resources are available and doing it before transport is usually a better idea, rather than just shifting in the ambulance and then worrying on the way that, what is going to happen inside. So always you think about the local resources that are available. Your physical presence will help in terms of planning. Your nurse is there, you are there, your skills will help. You can put an IV, start the fluid, but, just recheck the sugar, make sure that whatever local resources are there with your expertise, you can use it right there before making a quick move. And stabilize the baby. So again, airway, breathing, temperature. Make sure that the sugar, if it is low and there is an IV cannula, specifically if there is a long transport, and assess the circulation and needs for bolus or inotropes before starting. Always document. So, have a documentation sheet. So simply assessing is not good enough. Document your assessment and also the medications and stabilization, maneuvers that we have done, and communicate with the family and also with the referring team. So the family also will be in a big stress because the baby is being suddenly shifted to a new center. So communicating with the family is extremely important. My most feared part of transport is the walk till the ambulance. Because what happens is that in majority of the places, you might have a best ambulance, you might have a globetrotter, but that globetrotter won't reach the nursing home, where there is probably sometimes we have had babies who have been resuscitated on a platform of a kitchen, and on the floor, and there is no lift sometimes in the nursing homes. So there is no way your equipment can reach, the where the baby is. So there is still, I would say, in my practice, every third transport where we have to simply take a baby tray and bag the baby down, or take a neopuff and bring the baby down till the ambulance. And that is my most feared zone, because one, you need a high flow oxygen. For neopuff, you need 10 liters per minute flow to sustain a continuous power, which becomes a very heavy cylinder. There is no power source during that time. You are either climbing down the stairs, or you are making a walk till the ambulance. That involves lifting and shifting of the baby, so a lot of movements happen. So with central line, intubation, chest drains, that again become difficult. And that is the time where you can't tell the family to not be around, because it's a no man's zone. It is neither the NICU nor the ambulance. Ambulance, you can at least tell the parents to sit ahead, or the family to sit ahead. Here they will be walking with you, watching that what is happening. Okay, and there is limited manpower, because this is the time where the referring doctor will just be relieved, and he will be sitting and sipping coffee as you take the baby to the ambulance. So make sure you have enough manpower. Call the team of the referral, hospital till the ambulance, till the baby is stabilized. I usually get them all the way till the ambulance and make sure the monitors, everything is stable. Then only we, bid farewell to them. So this is like a very dreaded time in transport. So coming to the monitoring strategies, which is, predominantly what our exciting workshop is about. So monitoring is not always machines, right? So when you are actually traveling with a baby in an ambulance, what the baby gets is actually a 2:1 attention. In your best NICU, you have 1:1 nurse, but here in the ambulance, the baby has two people, one nurse, one doctor, maybe one more attendant only looking at the baby. So don't ignore the clinical part of monitoring. But I will also go through some machines and new technologies that are available. And monitoring, as we know, can either be some continuous parameters, or it could be intermittent parameters. So what do we want to know continuously? You want a very good monitor that records the heart rate and SpO2 constantly, because that is, going to keep our heart rate in pace. Temperature also, there is more than enough evidence to say that transport hypothermia or admission room hypothermia directly impacts mortality. So you want to ensure that the baby has a stable temperature. You want to continuously probably look at the baby's color, activity, and tone, at least, every few minutes. And ideally, a lot of units and lot of machines have now come up with a respiratory function monitor, which I will sort of discuss. So essentially what you do in the NICU, a monitor which shows you some graphics, leak, so an additional input or stimulation for the brain. So when you can't see the baby constantly. And then obviously you want to have some intermittent monitors. You don't want to touch the baby again and again, but maybe if you feel that something is off, then you would want to check the pulses, capillary refill time. Once in 15 minutes, 30 minutes, if the baby is on inotrope, you want to check a non-invasive BP. You want to check the fluid intake for long transports, which last a few hours. You also want to check whether there's been any urine output. You want to see the chest rise and air entry also intermittently to ensure that the ventilation is good. And ideally, you would want to do some labs also. And the available labs that we can do is a sugar and a blood gas. So we'll go through these monitoring strategies in a little bit more detail regarding what can happen during transport and what is the feasibility of it. So I think pulse oximetry and heart rate is what, everybody does, most units in India do. And it could be like a simple pulse oximeter, which is like an absolute mandate basic, because color assessment, as we know, is not sufficient, especially in the bad lighting. If the child is, inside the incubator, sometimes you have to wrap the child. So you can't even see, if the incubator is not there, then you can't even see the color or the chest. The pulse oximeter should have a neonatal probe. There should be a battery backup, and preferably a good real-time technology like SET technology. It is prone to artifacts. So, that alone may not be very, very reliable. As the ambulance moves, as the baby moves, there could be probe displacements, frequent movement artifacts can happen. So 3-lead ECG, like we do for neonatal resuscitation, along with an SpO2 monitor is usually recommended. And it does make your transport life easier, because that is a real-time monitor. It is less prone for displacement. It is much more accurate, and you get a dual heart rate reading. So you know that, one of the two is off. You don't need to jump out of your chair. So lesser needs to slow down the ambulance and, recheck the baby. You know that, okay, the ECG monitor is showing 130, SpO2 probe is showing 70. So probably let's check the SpO2 probe. So Strongly recommend to have a 3-lead ECG along with your multi-para monitor. Very easily available. Most of the current monitors have that. Temperature, again, like I said, that there are various ways to maintain temperature during the transport, and a transport incubator is probably the best option. And the Globetrotter is available, Draeger. There are many, other Indian companies also who make a very good transport ventilator. And ideally, there should be a skin probe with a continuous temperature monitor. So as you can see on this right side picture, there is 2-3, areas where there is a display. One will be your set temperature, one will be baby's temperature that the probe is reading. Some of the incubators even have 2 probes where there is one central temperature, like in the first talk we heard, and one is a peripheral temperature, which can be on the hands and feet. Because cold stress, the baby's first peripheral temperature will drop and then the central temperature will drop. And if there is again transport, with kangaroo mother care or in an embrace mattress swaddle, then again continuous temperature monitoring becomes very difficult, because that means you don't have the incubator. So then manual checks become very cumbersome, because you have to, again open the baby, put an auxiliary probe. So I think from the temperature perspective, extremely important to maintain temperature. Use a continuous temperature monitoring system with the probe on the abdomen, just like you would in the NICU. And if there is a single probe or a dual probe, either way, it should be a continuous display. Coming to perfusion assessment, the color of the baby you can intermittently look, central color, peripheral color, which will be probably give you a very, very rough or a vague estimate. Capillary refill and pulse volumes you can only intermittently check, maybe once in a few minutes. NIBP, again, you need to check once in few minutes, depending on what the the BP is, or is the baby on inotropes. Again, during transport, we need to ensure that the correct cuff size is there. And this is also prone to some artifacts due to vibration, but BP trends can still be useful. You had one BP recording before transport, so then you know the baseline and then you can trend it from there. So perfusion assessment, heart rate, color, capillary refill, pulse volume, NIBP, you'll have to give like an overall assessment to finally decide what is the perfusion of the baby. Again, in some sick babies, this can be tricky with PPHN, who are off color, also having some cardiac dysfunction. So it does get a little bit tricky if the baby is sick. But if you have a very good solid baseline assessment, which is, multiple parameters and very objective, then it is useful for you to trend. Coming to fluid and metabolic monitoring. So keep, the pumps and everything, all the machines are prone for error. So make sure that the pump is set at the right rate. And actually the fluid is being delivered. So it also shows the volume delivered, because sometimes the IV line might get displaced. So keep checking the IV site that it's actually going to the baby. Sugar check during transport can be done if fluctuations are expected. Urine, like I said, for long distance transport, you want to ensure that the baby is passing urine once in a few minutes. And point of care tests are available, which need to be carried for sick baby transports, which is glucose and your portable ABG monitors. So portable ABG monitors again are very easily available, iStat or GStat monitors. And they can, the good ones can actually give you many parameters. They can give you electrolytes, they can give you calcium, they can give you pH, all the blood gas parameters, CO2 as well. And it is always a good idea to carry it. And before, especially in cases of asphyxia, PPH and transports, it is always good to do it beforehand, because that will also help you, stabilize the baby in a better way. So once you know that there is acidosis, you can plan like that. If the CO2 is high, you can adjust your ventilator settings. So for sick babies with PPH and asphyxia, definitely recommended. And like I said, lot of machines are available. So it is not something that is only available in the West. In our BC transport team, we used to regularly carry the iStat machine and check a gas and document it before transport. And what way to take it? You can take it from the capillary if the perfusion is good. Otherwise, you can take a venous or arterial sample depending on what is, easiest. But for sick babies, it is always a good idea to document it as a part of your pre-transport checklist. So very much feasible and possible to check a blood gas before transport. So what is respiratory function monitoring, or RFM? So whenever what we were monitoring till now was the vital parameters, that the baby's color is off, say the saturation is dropping, or say, the baby's heart rate is fluctuating. So these are all late signs. So you don't want to catch a late sign, after things have fallen apart. So respiratory function monitoring will actually help you to, for babies who are on ventilator, help you to catch things early before there is a problem. So, if your ET tube is getting obstructed, or if there is a ET that has got displaced, or if there is some disconnection, you want that alarm to be faster, because the indirect assessment of ventilation that we are doing physically, which was your heart rate, SpO2, chest rise, color, they will be late and you might miss it because you are not constantly watching the baby 100% of the time. So respiratory function monitor basically essentially takes back to your ventilation graphics, class, or your ventilation graphics learning. They are basically graphical waveforms and numerical values also of peak inflation pressures, PEEPs, tidal volume, leak, minute ventilation. It can be having, along with it, a EtCO2 attached to it also. And basically that is standard of care in the NICU, right? So we do a respiratory function monitor for all babies on ventilator. They will all have this display for us. So why not use it in the transport? So lot of the newer transport ventilators, Accutronics, and the Hamilton ventilators are having respiratory function monitor. And there are also some indigenous monitors that are being designed for transport use only. So this is basically the Hamilton system, which is very, very popular in the North America. So you can see that it has a very clear respiratory function monitor. It has EtCO2, it has a continuous temperature display, and it can be mounted on a trolley, to go in the ambulance, go in the NICU. So it can travel everywhere along the lift. So this is how the displays work for the respiratory function monitor. As you can see, it is showing the pressure time scalar, PIP, PEEP, the total inspiratory time. It is showing the flow time scalar. So the inspiratory flow, then there is a pause, then expiratory flow. Here again, inspiratory flow, then pause, then expiratory flow. It is showing the EtCO2. So this one has a EtCO2, and EtCO2, obviously the CO2 is going up, which is the expired CO2, then it goes down. So expired CO2 goes up. So that graph also gives you an idea that the ET tube is in place. And the tidal volume. So this is the volume and time scalar. So this is telling you the tidal volume. So inspiratory volume, and at the end of inspiration, you have this small expiratory tidal volume. So these many parameters, or sometimes even, more parameters are available on display with good respiratory function monitors. And this graph, can anybody type in the comments what has happened? So you can see that the gas flow has stopped. No flow towards the infant, no flow away from the infant, and expired CO2 is constantly being shown. Tidal volume, expiratory can't be detected. Inspiratory tidal volume is there. So this is a ET obstruction. So a complete tube block will appear like this. You can see that there is no flow towards, the infant, and look at the volume graph. It has just completely gone down. So this will give you, an alarm before the baby actually deteriorates. Here also there is an event happened. You can see the first half of this on the left side. You can see the graph, what is happening. The pressure is seeming okay. The flow is okay. And look at the volume, what has happened to the volume. So here the volumes are okay. And suddenly there is no flow in this negative part away from the infant. And the volumes are going up, up, up. Like there is no end to the volumes. They are not returning to baseline. So what does volume not returning to baseline mean? Somebody wants to type that? Volumes not correct. So there are already few good answers. So that is a ET dislodgement. So the volume not coming back to the baseline means the ET tube has been dislodged or displaced. Again, it helps in optimizing during transport. So here you can see that the PIP is set and the tidal volumes are huge, almost 50 ml. So, for a 3 kg baby, that is a very, very large tidal volume display. You can see that the volumes are very, very high and the PIP is around 30. So this again will help you say that, okay, maybe the lungs are now recruited and you can come down on the PIP. And there you can see that the tidal volumes are a little better. So 7 ml per kg. So the respiratory function monitor basically helps us fine tune things. So you're not now waiting to reduce the settings till you reach the unit. So if it's a 2-3 hour transport, you don't want to overventilate, hyperventilate the baby. You don't want to have pneumothorax, problems during the transport. So why not use this and optimize? Because anyway, there is a trained person who's there in transport. There is a nurse who is available full time for the baby. So might as well utilize that time for there. And there are, air oxygen cylinders. Once you install it in your ambulance, then you can use a blender also. So blended oxygen, only if you use a blended oxygen during transport, it is usually helpful. Most of the ambulances in India still have only an oxygen port. So you will be sort of doing 100% oxygen transport. Coming to CO2 monitoring, there are two ways to do non-invasive CO2 monitoring. The transcutaneous CO2 is more accurate in neonates, but again, during transport, there is a problem because, you can't check the site. The site gets heated to 43 degrees. It needs calibration. Air bubbles can get trapped. So it is a little bit, it's a little bit fussy or a fidgety device. ETCO2 is very simple and easy. It is not accurate, but the trends are useful. So ETCO2 in newborns, it will help us decide whether the tube is dislodged and what is the trend happening. That much information it will give, and it's very easy. It goes in line with the above your flow sensor. So you can very easily put it. So very much more convenient. But CO2 monitoring also, ideally, if facilities are there, it is recommended that you do it during the transport. So what is new in transport? What extra monitoring or what extra advances that have happened? So, there are cooling therapy. So first, till a long time, there would be passive cooling. That is, the warmers would be off. And, you can, one stage better is that you keep the warmers off, keep the baby cold and put a rectal monitor. So at least you monitor. But right now there are active cooling devices. So the Ticotherm Neo is a very small, as you can see, handy device that can be used for active cooling during transport. And HFOV and nitric oxide has been used in transport. So the largest case series from India has come from Rainbow Hospital, where they have recently published a case series of 24 babies, neonates, who got INO and HFOV during transport, and they have reported a 70% survival. When this paper came, I called, my colleague, Dr. Nalini Kant, who is the primary author, that, where did you buy this and which company sells the transport HFOV monitor. So he said that nobody sells it. So they actually had to customize it. So they called their engineer, they got the HFOV machine from Accutronics, which is, widely used in Europe for transport HFOV. And they got it fitted in on a stand and sort of custom made this. They use the SLE inosis for the nitric. So, if you want to really up the game and try to, do more advanced and more sick transport, you do have to customize a few things and, set it up, because it really is not always easily readily available that, one company is going to sell it to you like that. So lot of customization, lot of fine tuning goes in that. They had to fit an air cylinder separately to blend it and put an air port so that, the ventilator input has two air and oxygen, both ports are there. Whereas most of the ambulances, like I said, will only have an oxygen port. So you might have to do a little bit of customization, but this is an Indian case series. So something that is very recently published. What about telemedicine? So telemedicine basically is a prerequisite. You need a cordial transport team. You need to have available manpower, good network and connectivity. But the scope of telemedicine is very vast. There has been times where, on a video call, I've instructed a GP to put a chest drain till our transport team reaches, and, guiding them about ventilator pressure settings, adjusting settings, sending x-rays. So in some, some ways we do a little bit of telemedicine. But ideally, if there is a cordial relationship, regular relationship, the other person's skill set. So it can be done in a little bit more systematic way, where by a video call or a simple FaceTime call, you can assess the baby, you can guide the team, adjustments in fluid rates, CPAP settings, ventilator settings can be done. And sometimes, like I said, troubleshooting of machines, guidance regarding procedures can also be done. So there are a lot of papers on, use of telemedicine during transport. And what about a centrally operated network in India? Is it feasible? We think that, okay, no, there are so many government sectors, private sectors, nobody is cordial, then how is it possible? So one private institute, the Manipal hospitals have actually done a quality improvement project where in the city of Bangalore, all their 7, 8 or, multiple units, they built, set up a centrally controlled hub center where all the transports could be coordinated, where they would know, the availability of live bed status in the network hospitals. And there was a constant helpline during the transfer process. So this is a very small study, again, a single center study, and it could be done because all the hospital networks were their own partner hospitals. But again, something that, can be looked upon from the administrative point of view also, that, this, because again, in, India, the traffic, the roads are all a big concern. So if it is a coordinated system, the babies will definitely be benefited. And, this model sort of tells us that at least it can be something that is feasible in the near future. This was a study by one of my fellows in Mumbai, so neonatology trainees. So what we did is we did a early physician-led transport of ELBW babies. So what we did is we told all obstetricians that if there is a ELBW baby being born, if you can't get the mother to our hospital, please call our team. Don't call us after delivery, because that was a very common trend. They would call us, baby is born, we are doing ambu, and baby is moving, can you send our team? And depending on the Mumbai traffic, sometimes it would take us 20 minutes to 1 hour to reach. So this, after we sort of repeatedly, reiterated to all the obstetricians who were sort of in touch, they started calling us for, in utero, what we call as early postnatal transfer. And when we compared it to the mothers, so whenever in utero transfer was possible, they would send it in utero. But whether the mother was in active labor or, transfer was not possible, they would at least call us. So our team would immediately leave. And it was a neonatal fellow who had at least 1 year training in NICU at our hospital, and a neonatal nurse. And with that, at least we could improve outcomes. So, they were at least comparable to the in utero transfer. There was no statistical difference, but it was like a non-inferiority sort of a study. We didn't aim to show that that is superior, but we at least wanted to make it better than our outborn babies, which are stabilized by a team, which is, a local team or an untrained team. Technology wise, there is, every few months or few years, you see like a new monitor. So this is a very handy, this is by the Australian group, Peter Davis and team, a very handy respiratory function monitor, which can be fitted in. So this is just like your pedicap. So your colorimetric, ETCO2 that you use for NRP, where you see that the color change means your ET tube is in. This can be connected at a neopuff. It can be connected, on any ventilator circuit, and it gives you 3-4 parameters. It gives you the tidal volume. It tells you if there is a major leak. It tells you the rate. So, this is again a recent publication where, people are looking at building smart things to have a little bit additional monitoring rather than just relying on chest rise, air entry, and so forth. So this is again a very recent update. What about the air transport scenario in India? So back in 2011-12, my first air transport was done in an Air India flight. It was a baby whom we were getting to KIMS Trivandrum from Bangalore. And the baby was having, I think, a G-tube, tracheostomy, needing some oxygen. And I remember that there were some letters that my mentor that time, Naveen sir, sent. And then there were some permissions that were there, and they had cleared the first row for us. So me, one nurse, the baby in the nurse's lap, and I think we had some ambu or something manual that was there, and the airline permitted us. We said that we will take responsibility for whatever happens, if anything. Their family's consent was taken, so that that is how it started. It was a completely commercial flight. They were like, it was full, the next all rows were full. So coming from there, right now we are at a stage where we have air ambulances. They are still quite expensive. The cost can vary depending on the distance and how high risk is. It can be minimum 5 lakhs and plus, but at least we have good ambulances or chartered flights available, and this is how they look from the inside. So you can see that the ventilator is well secured. Then there is a multi-para monitor on the right. There is air oxygen circuits. On the other side is where the physicians sit, and this is where the baby incubator would come on the side. So on top of this will be the baby incubator. So again, you need a trained manpower. Majority of the air transport or air ambulances have their own manpower, which you very much need. But typically, whenever we send, to get a baby or send a baby, we send our own neonatal trained physician, because newborn is something that, all other doctors are very scared to touch. So we always send our manpower as well. So it is a mix of the flight or the air ambulance manpower plus our manpower. And again, the leaders in doing HFO and INO in air in India are again from, the Hyderabad group, the Rainbow Hospital. So they have, I think they are in the process of writing the next case series, which is your HFO and INO used in air transports. So they have done a few. So it is again feasible, but you'll have to customize your equipment accordingly. So the key messages from the talk is that the transport success is actually multifactorial. one of the important factors is the timeline. You can't take 1 hour to prepare, so it has to be prepared. There should be a ready transport kit which has a monitor, multi different size tubes, CT tubes. So everything possible that you can see can be there, and some add-ons can be taken as and when needed. So if you have like a cooling device which is portable, that need not be carried every time, or if you have a nitric oxide inosis, that need not be carried every time. But your basic transport kit should always be ready. Always stabilize prior to starting your return journey. So if you have gone, reached the center, think that you have better resources there in that hospital rather than your ambulance. Monitoring, we have a lot of technology, lot of monitors, RFMs, BP monitors, everything is there. Blood, don't forget your clinical monitoring. And the whole effort of transport, monitoring is to make it as close to the NICU. So I think what will come in the future is that, whatever you think of, there is this, new camera. It just looks like a digital camera which can shoot an X-ray. So I think once that technology becomes more prominent, you can soon have an X-ray during transport. It is just like a camera, you click it, you keep a small cartridge or, your sheet under it, and then the X-ray image comes on your phone. So I think the monitoring is also getting as close to the NICU as possible. And clinical, like I said, there is actually a 2:1 attention. There is 2 people for 1 patient on most times during transport. So you have actually a better watch. And doing regular training and simulations is the only way forward, because in India, the nursing, the junior doctor team is always a rotating population. Your neonatal trainees, nurses will always, after 3-4 years of learning, they will move out. So the training session should be constant, which is always lacking in many institutions. So thank you for your patient listening. I think we can take some questions at the end of this talk.
Dr. Shamla, over to you. Excellent session. Dr. Shamla. Yeah, you can moderate.
Yeah, I think there were some questions, Anish. Very good, nicely summed up. And it's no joke transporting a baby in heavy traffic. Well, I had a question about what do you do when the baby is moribund and you think baby is not going to make it or something like that? What do you do? How do you deal with the family and the referring unit? You'll lose goodwill, but what do you
Yeah, that's a very pertinent question, ma'am. So a lot of things we have done in the past. So normally I always try to get one family member with us in the ambulance, because communication, sometimes network becomes a very bad thing, bad, issue in Mumbai or anywhere. So you don't want to be alone with the baby where, you come back and tell the family that, okay, we didn't make it. So usually one family member sits ahead with the driver, and, we are behind with the baby. Generally, if the baby is moribund, we obviously take a very high risk consent before transfer, and we explain the family that this is the risk and benefit. There has been maybe 1 or 2 times, once in Vancouver and once in India, where we started the transport and actually turned back, reached the old hospital, did CPR and declared that the baby didn't make it. Because for them, at least having the baby near them, at the time of critical illness, it depends on how far you are from the hospital. So I think what practical things that go in my mind is, number one, that what is the nearest center? If I'm almost reaching my hospital, then that's where I go. If I'm just started the transport and the baby suddenly goes into bradycardia, I just stop the ambulance, try to revive the baby. If the baby comes back, in 10 minutes we are stabilized, we explain to the family and move forward. And if it is not baby reviving, then the best thing is to probably move back to the same place. The medico-legal responsibility, once the handover is done, lies with the transport team. So you have to take responsibility, because you have explained to the family, you have taken consents. So then the onus is on the, transport team, because we are the more experienced team to handle that situation. So that way the, medico-legal implication, and I think the families also want that, that y'all came, y'all tried. And so there has actually never been outburst or a relative concern whenever this situation has happened, because what they are seeing is that there are 2 people dedicated only for one baby, and they have come all the way, they have tried their best. So NICU may sometimes parents might have outbursts, but in transport, actually, in my experience, there has never been a outburst from the family perspective.
Given the current scenario, I think we need to protect ourselves also,
So
what
correct.
about
Yeah.
Meera?
Just Just a comment on that, actually, yeah, when the families actually had decided to move, as Anish said, that's what has my experience has been, that they have decided to move and they are probably ready and accepted the fate, and like but at the same time, as Dr. Shamla pointed, sometime we have refused the transport as well. If the condition is too unstable, then explaining the family, and then maybe not too stable to transport, then probably we can probably refuse it. But anyway, we are deviating from the topic. Over to you, Dr. Shamla. Let's take, lots of questions have come.
And what about Mira cradle for transport of hypoxic babies?
So that can be used. It is again a sort of a portable device, but I would strongly recommend to have a rectal monitor. So I think the main problem with any of the non-servo controlled cooling devices is that we need to have a rectal monitor.
They're as good as
That-
ice packs.
Yeah, yeah.
There are questions about type of ventilators for HFOV during transport. I think you may have already covered.
So the Accutronics, yeah, the Accutronics one is there. It is again, like somebody has correctly mentioned in the slides, that it is not, approved for air travel, but it is approved for transport HFOV, and they don't have the rights to sell it for transport in India, but they have the rights in Europe. So I think when the Rainbow team also took permission from them to sort of customize it on a stand and sort of build it. So it is not like a very approved option in India yet. But again, if you have no other option, then that becomes the only possibility or the only option. So the Fabian Accutronics ventilator is pretty good for HFOV during transport.
There's a question on HFOV during air transport.
Correct. So I haven't done the HFOV air transport in our center in Mumbai. But like I said, we did discuss it with the Rainbow team once they had their successful HFOV. I think they have had 3 or 4 babies already, HFOV and INO in air transport. And they use the same one, the Fabian Accutronics device. So they basically, I think somebody has commented that it's not approved for air transport. But I think that is also the advantage of being in India, probably, where, when there is nothing available, I think you can just take it. So it has been used in India. Without
Giving paralysis during transport for ensuring ET safety, tube safety.
So sedation and paralysis again is like you would use in the NICU. So if you feel that the baby is very labile, PPHN like baby, maybe some sedation can be used. If the baby is having, so just routine paralysis definitely is not indicated for transport. But sometimes if the baby is very active, you might need to sedate it. So maybe some fentanyl or, some opioid infusion can be used. Intermittent boluses may be better if the problem is not much. But otherwise, if you feel that it's a PPHN-like scenario, we rather prefer to start fentanyl infusion before transport because you don't want the baby to fluctuate up and down.
And Dr. Sanoj wants to know what you'll do for twins.
We usually take extra manpower. There have been times where we have heard that there is one baby and we reach and there are 2 babies born. So then you just make do. But for twins, usually what we do is that in terms of the ambulance, practically we have only one neonatal incubator. I think most units will have only one incubator. So we keep both the babies. Usually the twins will be preterms. That is why they need transfer. So we keep both the babies in there, and so far we have had quite a few twin transports. One of the twin goes on the ventilator, one of them is on neopuff. So not sort of ideal, but that is what we have been doing practically for the past few years. So one of them, gets whoever is more stable probably, or the bigger twin you can take on neopuff. But best case scenario, you need double the equipment, double the manpower.
Yeah, we did 2 ambulances actually.
Correct, exactly.
And in fact, it's just interesting deviating, but we sent 2 ambulances to Ideal Thing, and the whole scenario was so big that the family got scared and they first refused. I said, well, this is something big happening. I don't think we can afford it, We twins, 30-weeker twins, we were transporting from Kalyan, so from a remote place, and then we sent 2 ambulances. So sometimes we try to be ideal, and it is beyond imagination for a lot of people because we wanted 2 equipments. So sometimes, as Nish said, practical. One neopop or one bag with one this thing and fitted in one incubator might be more practical. again, more aspects we can discuss in the transport station in the workshop. But yeah, some more questions are there.
Oxygen titration during transport.
Correct. So this is something that ambulances in India don't have. So you will have to actually get it fitted in your ambulance. If you claim to have a neonatal ambulance, then get a big air cylinder and, have an airport, because only if there is air and oxygen will a blender, work. So
So you have to
can you?
modify the ambulance, yeah. And also you
Correct.
probably have to have a provision of a additional cylinder. Suppose you have to change. If a long transport has been there has to be the connection below the ambulance. You can be two cylinders can be stored, and then the switch. Also, I think connecting to the low flow, high flow to the ventilator or to the oxygen. Also, it has to be, already planned. So again, we did the same thing when we planned the ambulance. It was a good learning to plan the ambulance, how this can be controlled and what practical aspects are needed to actually use it. Yeah.
And about the opioids on transport, how do you give this given the licensing laws in India?
Oh, Dr. Kiran from our unit. Yes.
So we typically take it. So if I know there's a PPHN baby, I will take it from my own unit, because getting it from the other unit will be very difficult. Like, sign of parent, sign of this. So that is a little challenging, situation. Any thoughts, Kiran sir?
So I think Jugad. So basically, you prescribe for somebody else and then you can take it, because you cannot prescribe unless the patient is admitted and they
Correct.
won't dispense. But always there is an emergency drug is available,
Yeah.
the emergency kit. So I think that can be utilized, and then once the patient comes, then you put it on a prescription on the patient.
Yeah.
But yeah, you can carry. And most of the remote places where we go, again, a lot of time even fentanyl is not available. They use midads. So better to carry morphine and fentanyl our own. But legalities, I think that is the question what she's pointing out. Probably is not very clear. What we are doing is
Gray zone. Yeah.
gray zone. So I think yeah, if somebody questions, probably yeah, we will might be difficult. But again, in practical scenarios, it is important to sedate the baby well during the transport, because it's very unstable situation for the baby, especially preterms and PPHNs and cardiac.
Yeah. So technically, once you take over the baby's care, you are responsible for the baby. So you can take the family sign for that opioid use also, if you want to be by the book. And
Yeah.
then, because even though the baby is not admitted, it is still under your care.
Absolutely,
I
absolutely.
think
Implied, it's a
last
implied
question,
consent. Yeah.
probably. It's almost 10 o'clock. Using AMBU in a moving incubator, moving ambulance, I think, isn't it risky? I think we've all done it at some stage.
Yeah.
I ever
Best avoid it. Yeah. It is
best to
still,
avoid.
still very scary. Yeah.
It's very.
Okay.
I think having good ventilators is important. Again, just we have done 10, 11 hours transport in our hospital here. We are waiting to our first ambulance, air ambulance in India. I think I've done lots in overseas, but Indian challenges are different. And I think Anish, your talk was excellent on the practical aspects. And the scariest part is actually reaching the baby. That's everywhere. I think most of the time even the lifts are so small, the equipment doesn't fit in most of the places. So you end up umboing also. Even if for the neopuff, also you need a oxygen cylinder
Hmm.
carrying with it. Sometimes even the whole thing carrying also is difficult. So India has its own challenges, and but I think important uh, focus of this talk was continuously monitoring. So your two eyes or four eyes you have on the baby during transport, as Anish rightly mentioned, you have to be very vigilant. And sometimes, many times, that color, your clinical takes up this thing, because sometimes the monitor is somewhere else, or especially when you're shifting the baby in up to the ambulance. So that portion is very critical. Remote hospital to reaching your comfort zone of the within the ambulance. And then well-equipped ambulance, as he rightly pointed, probably highlights the crux of the good transport. I think there are a few more questions, Dr. Shamla. I think ET
That
displacement.
almost looks like it's the end. I think, what is the commonest cause of crash in transport? Crash
I
of the
think
Airbus.
probably top two will be probably tube displacement, pneumothorax.
Baby. Yes.
Yeah.
Dope. I think the dope applies here as
Yeah.
well. So ET displacement is more common. So again, as Anish pointed, we will bring some ETCO2 monitors in the transport workshop and the hands-on. So again, that are not readily available. So your ETCO2 detectors or ETCO2 monitors, which can be connected, they are not available. But that something is handy during the transport, because you know your auscultation, air entry in a moving ambulance is difficult. But if you have a ETCO2 detector, then probably, and checking the position probably is the best way to monitor the endotracheal tube, the placement. And but yeah, you need a secure trip. So sometime longer transport, you might prefer to do a nasal intubation, because that's more secured. You know, less chance of extubation, and a tight, secure. Then again, how you position the ET and the baby, all those things also we need to monitor to ensure. And yeah, again, equipment failure, as Anish pointed, oxygen supply goes down suddenly, not monitored. Suddenly, oxygen is gone, and sometimes it alarms, but you don't notice. So that is again another cause. But yeah, ambulance failure. I lost one baby. Just ambulance had a crash, like the tire bursted. Then they tried to shift the baby to some other small ambulance, and then it was a chaotic transport. Third party, not we were doing, but baby was coming to us. So that's why we almost now prefer to go ourselves and bring, rather than asking some third party to transport. So controlled transport, I think, is important. So
So
looks like we've
do we
covered
take
most
any
of the thing.
or shall we? I think Dr. Karthik Nagesh will be talking on transport as well, isn't it? Tomorrow he has a.
He's more on
Right.
tele monitoring, but yeah,
Right.
something he's covering in transport as
Sorry
well.
for joining in late.
Oh, Dr. Karthik, you're
But
here.
hmm,
Great.
sorry, I actually was in another conference, so thank you for inviting me. Tomorrow I'll be joining. I'll be
Yes.
talking on my experiences on Telenico. But having said that, Shamla, you're right. I've started a newborn transport network in Bangalore, combining all the 10 Manipal hospitals in Bangalore. We are running with a central helpline, and it's telemonitoring as well as a sort of remote monitoring we are doing while transporting. Maybe briefly, I can touch upon it tomorrow during my talk on
That will be great.
Telenico. We are basically, I'm going to talk on Telenico tomorrow. Hmm?
Perfect. Teletransport tomorrow. So stay
Thanks.
tuned tomorrow. I think we are almost 10 o'clock. We have lots of sessions tomorrow. I think, thank you, Dr. Karthik. So, Dr. Shamla, I think you should conclude anything else, or
No, I think we should take. I think good talks by everyone, and thank you for sticking to the time. We finished. I mean, at least about 10 minutes past 10. I think that's what my clock says. We had
40 maximum. Yeah.
260, I think,
40.
a peak.
Yeah.
So about half of them have left by now. So tomorrow, I think we'll make it crisp and on time. So thank you very much, everybody, for all their great and lectures. So I think it's time to close.
Yes. Again, recap for tomorrow. More talks remaining here. As you can see, trend monitoring, AI application in monitoring, NEERS, neurocritical care, non-invasive cardiac output monitoring, if time permits, sleep studies, and then telemonitoring. So, and we have all again a few international speakers also talking tomorrow. Valerie Chalk from USA, Dr. Soni from Qatar, and Dr. Khurshid Mohammed from Canada. And Dr. Karthik, as just now mentioned, will be talking on telemonitoring. So, a lot of lengthy marathon of talks tomorrow. So stay tuned. Those who wants to join again, you will get a link of the Zoom link in the email. So check your email for the same link to log in, and you can share the registration link also for the Zoom with your colleagues or friends who are interested to join. And those who wants to come into Chennai for workshop, hands-on workshop, please still do register. We still have few spots left. I think 7, 8 spot left for the workshop for practical aspects. We can talk more in the workstations about all practical aspects of the monitoring. So again, thank you, everyone staying till end. Thank you, Dr. Shamla. Thank you all
Okay.
the faculties who have contributed today.
Okay. Good night. I think the weather has been kind. Our Wi-Fi is lasted till the
Yeah,
end.
your Wi-Fi lasted. Hope same tomorrow.
Okay.
And hope it clears by workshop so that we have no
Absolutely.
trouble during the
Yeah,
workshop.
yes, yes. Okay. Thanks and good night.
Thank you everyone for joining. Thank you. Thank you very much.
Thank you.
Okay,
Good
see
night.
you tomorrow. So, yeah, thank you. Thank you, Anish. Again, thank you tomorrow. Yeah, bye.